Hello, hello, morning, how are you? Asante, pole na wewe. Unaona meseji yako, kikao kipo. Sasa hivi tuko kumbe, tunasubiri tu kama dakika 5. Yaani kwa huko ndani wewe unajua tena maandalizi nini fanyike ili usifanyike. Yeah. Hiyo kumbe tu ambao ukiingia una face moja. Ukiingia hapa chipe chill
The acting vice chancellor Muhas, Professor Muhas, the acting our mentor, Professor Sima, who is also going to be co-chair of this session. Dear participants who are present here in this room and those who are also online, we welcome you to the first Muhas Grant and Innovation Symposium, which is taking place today. This is an initiative that the Director of ICT to consider support as we try to implement and establish individual health innovation hub. So we are organizing this symposium, one, to share experiences in the digital space, and also we'll be consulting tomorrow different stakeholders together requirements on how we are going to use the hub, and also plans to make sure who has played a vital role in establishing digital health innovation space. This is part of implementing the strategy which development was led by Muhas. We also have participants from Zanzibar, who also has led the same initiative of developing Zanzibar strategy. The symposium is going to have one keynote speech, which is going to be online from our mentor in Sweden, Professor Saya of Anderson. We are going to also have 12 presentations, 6 physical, and is also 6 digital. We have representatives from the government ministry responsible for health, the Ministry of Health, so Kamisemi. And we also have a presentation from IGA, which is going to be online. Unfortunately, the director responsible travels this morning to the government. We have so far listed 104 participants, about half virtual, half physical, and these are coming from 10 countries all over the world, including Sweden, Norway, UK, US. We also have Dan with us from the US, who is going to present on engineering and related fields. Thank you, Dan, for coming. We thank you all for coming, and we ask the ICT to provide thank you for your attention.
Thank you, Dr. Felix. Our permission is to honor. May I request to introduce yourself to that we know this year. So we can start. No particular order.
Good morning. My name is Juliana Buke. I am an assistant director of the Directorate of Statistics. I'm also part of the members of one development and innovation research group. I am here as a participant, but also part of the organization. Thank you.
Good morning. My name is Edward from the DIG, Director of SCG. Good morning. My name is Muhas. I'm a student of UDOM.
Good morning. My name is Saidi Kude. I'm a representative from Muhas Australia Government.
Good morning. The Lord Secretary of Friends.
Good morning. My name is Johanna Lanza, Amplified Muhas.
Good morning. I'm Bernard Senko from the Director of the Private Service.
Good
I'm aka Manu from the Director of
Good morning. My name is Dr. Kabika, Electronics and Public Engineer from Muhas Public Engineering Unit. I'm also the member of the Muhas for the Innovation Research Group, and also a member of the organizing committee of this event. Thank you.
Good morning. I'm Dan Schuster, CEO of Biomedical Engineering Technology Aid International, also known as Beta International, of Portland, Oregon, in the USA. And we facilitated since 2010 the development of biomedical engineering degrees in ordinary diploma and also Bachelor of Engineering or Arusha Technical College. And we now have memorandum of understanding with Muhas and also the
Good morning. My name is Dr. Debrada Santurubao, a member of Biomedical Engineering Unity, also a member of Muhas Innovation Research Group. Thank you.
Good morning, my name is Shaban Musega. I'm a graduate student from Muhas. I'm going to present the application of artificial intelligence technology in Sadat.
Good morning. My name is Christina Nyala. I'm a data analyst here at Muhas Project. I'm also a happy competition.
Good morning. My name is Astilis Florent. I'm a postgraduate student representative at Muhas. Thank you.
Good morning. My name is Barata Samuel. I'm an assistant research fellow at the University of the Life Sciences.
Good morning. My name is also Adenoga. I'm working for MAP. And I think it's but thank you.
Good morning. My name is Kwesi Kazoba. I'm a engineering student here at Muhas. Thank you.
Good morning. My name is Rebecca Chaula, System Administrator from the Directorate of ICT and a member of Digital Network and Innovation Research.
Good morning. My name is Mike.
Good morning. My name is Charles Howard from the library, and a student from University of South.
Good morning. My name is Yodaru Savas. Here as a participant, I will be presenting the Directorate of Library Services here at Muhas.
Good morning. My name is Chris Vika, tutorial assistant at Muhas, but also a programmer.
Good morning. My name is Sabina. I'm a senior business analyst. I'm a technical person in this meeting.
Good morning. My name is Rahim Mohammed Saeed. I'm an officer from the Directorate of ICT.
Good morning. My name is Liberati Rosso. I am an ICT officer and also technical personnel in this meeting.
My name is Joseph Pateri from ICT officer. I'm a technical support team.
Thank you for that brief introduction. And without much further ado, may I take this opportunity? BBC Muhas was acting with the guest of honor and also representing the Vice Chancellor who fortunately not make it in this morning following the loss of daughter of their team and his family that we are going to. BC PFA, Professor Silva, who is the co-chair of this symposium, distinguished guests who are here, and also joining us virtually, colleagues, ladies and gentlemen, all protocol observed. Good morning and good afternoon for those who are joining us from Asia. Good to see our honor. I would like to start by expressing my sincere thanks for joining us this morning as we achieve this very important and significant milestone. The first Muhas Innovation Symposium. We acknowledge that you have equal or even important commitments, but the fact that you have been able to come and join us this morning is indeed a great honor and privilege. Just of honor, I would like to take this opportunity to convey my sincere appreciation to Muhas management, distinguished guests, key as the speaker, Professor Sarah Omala Anderson, presenters, participants, and the organizing committee for making this symposium possible. At the Directorate of ICT, we are humbled by this opportunity to host this important symposium on behalf of our institution. In case of honor, my task is short. I invite you to address this together. I would therefore like to stop here and welcome you to address the official of this symposium. Welcome.
The Deputy Vice Chancellor, Professor Idahu, the Director of ICT, the coordinator, the students, the mentors outside, the Simba, the facilitators, the thinkers, organizers, and participants. But we did introduce ourselves, but those who are online did not introduce themselves. So I told to be a little more about what's been on. Can you do that? Let's do it. Is it this? Yeah, can you?
There are participants who are online, who are joined via Zoom. We have an opportunity for you to present yourself. Kindly, I see Lars Widerman. Can you introduce yourself, please?
Hello, good morning. Can you hear me?
Yes, we can hear you.
Excellent. My name is Lars. I am from Copenhagen, Denmark, and I am a strategic design director from a company called ManyOne, and we are collaborating with the World Diabetes Foundation on a project called the Diabetes Compass. So we are very interested in learning about much more about Tanzania and digital innovation and health in the country. So thank you for the opportunity to participate.
Thank you, Lars. We have Martin from Abu Dhabi. Martin, can you introduce yourself, please?
Yes, morning, everyone. Can you hear me?
Yes, we can hear you.
All right, how are you, Felix? Yes, I'm Martin Greifenberg. I'm a senior program manager at World Diabetes Foundation in the digital health team. And we are, as Lars mentioned, deploying a new digital health solution called the Diabetes Compass in Tanzania, among other countries. Thank you for the opportunity.
Thank you, Martin. We have George Liza from NACD. George, can you hear us?
Yeah, I can hear you. Good morning.
Good morning.
My name is George Liza, and I'm a system analyst working with the National AIDS Control Program. Thank you.
Tom from Norway.
Hi there. Yes, my name is Tom Newmark. I'm a social anthropologist at the University of Oslo, and I do research on digital and data-driven innovations in health in East Africa, particularly Tanzania, and it's nice to see some familiar faces around.
Thank you, Tom. Let's say Is there any way that can you hear us?
Hello, good morning. My name is Ibrahim Simio. I'm a medical doctor and public health specialist. I work with Gender TZ Tanzania and have interest in digital health as well. I'm glad to be part of this team.
Actually, can you hear us? Can you introduce yourself, please?
Hello.
Yes.
Good morning. My name is Desdere Wenga, and I work for Apti Associate Inc. in Tanzania as the Senior Technical Director for Information Systems, very much interested in the digital space. Thank you.
Thank you. Lilian.
Okay, my name is Lilian Salingwa, and I'm from Radiology and Imaging Department in Muhas. I am interested in digital health. I'm happy to be here. Thank you.
So thank you very much for those who are here and those who are online. And for some of you, it's very early morning. For some of us, it's already morning in Tanzania. So I'm informed that this symposium, it is meant to share experiences, get updates, technology of the areas of health and innovation. So I'm grateful that I have been invited here to open this symposium at Muhas, and let me start by saying that as part of the Muhas management, we are very happy and encouraged that such an important symposium is taking place at this institution. And yes, and as we all know, digital health is rapidly transforming the systems and provision of healthcare services. And Tanzania, like many other countries, we have developed and implementing its digital health strategy 2019-2024, which among other initiatives promotes research, innovation, and development in health digital technologies, and aim, of course, to improve the delivery of healthcare systems, services for better population health. So I think we need to continue taking advantage of improvement in technology in the health sector. And one of the strategic priorities in Tanzania digital health strategy is promoting research. We know that in health, like in other fields, we need evidence, and this evidence can be obtained through research. But we need innovation because technology is changing, disease patterns are changing. So we need innovation, and so that we can have evidence that can inform policy change. And universities and institutions like Muhas, we are required to collaborate with government and implementing this. So we are part and parcel of the team. So we need to support the government. And the Muhas has been actively playing its part. For instance, in 2020, that's last year, February, Muhas organized an hackathon on digital inclusion in collaboration with the University of Oslo, the National Institute for Medical Research, and the other collaborators in Eastern and Central Africa region. But also this year, June, Muhas organized a symposium specifically on the use of artificial intelligence in the health sector. So this indicates that in the period of 2 years, Muhas has been supporting the government in the implementation of the policy that is in place. But also, Muhas strives to continuously harness and adopt digital technologies in its core function. And the core functions of Muhas, like any other universities, are three: that is teaching, research, and service provision. So in all those three functions, we try as much as we can, based on the resources that are available, to make use of digital technologies. So Muhas has over 60 services in its ICT catalog, which which include both the infrastructure, systems and services to support teaching, learning, research, staff services, as well as administrative functions. But also Muhas has been collaborating with various government ministries, departments and agencies, as well as development and implementing partners to foster digital health and innovation and implementation and evaluation of digital health initiatives in Tanzania, both many of them Zanzibar. For instance, Muhas has led the assessment and development of digital health strategies for Tanzania, many of them Zanzibar. So today's symposium is the first of its kind because it involves a number of government institutions responsible for health and social affairs, as well as ICT and e-government. There are also presenters, and we have heard from the presentation. So we have presenters from different partners globally. We have presenters from Sweden, the United States, the UK, and other countries. So furthermore, sessions of the symposium will cover policy and governance aspects, implementation of digitalization, as well as prospects and opportunities in the use of emerging technologies. And this is one of the efforts to support the implementation of digital health initiatives that are prioritized in the digital health strategy. So the aim of this symposium is to share, as I mentioned earlier, experiences and expertise on how to appropriately adopt and use digital technology to transform and strengthen our system. And then we heard from the presentation here, we have students. We have undergraduate students that will. This is very encouraging because changing technology, it will be driven by the younger generation. And for the older generation also need to acknowledge that and make use of the young people that can assist us in implementing these strategies. So specifically in the symposium, we explore strategies to foster digital health research and innovation at Muhas and transfer digital health and innovation hub. So that's the plan that Muhas plans to establish a digital health and innovation hub that aims to support the Muhas staff, students, and the community in the field of health. And Muhas has a number of research agenda. The research agenda was recently revised this year. And in total 18 thematic areas. And among these, there is knowledge management and informatics. So digital health is already included in the priority areas for Muhas agenda. And this Muhas agenda were drawn from the national research agenda. So what we are doing here is part of implementing the Muhas research agenda as well as the national research agenda. And the research teams promote research in digital technologies and innovation for society. But also earlier this year, a multidisciplinary group known as Muhas Digital Health and Innovation Research Group was formed as joint effort under the directorate of ICT and environmental engineering with the aim of promoting research and innovation and to facilitate the adoption and implementation of integrated, affordable, evidence-based, and appropriate innovative digital health solutions. This is an example of how such initiative prospered. So we need people from different professional backgrounds. So this includes people from ICT, as well as from our limited environment, and really also involve others. The main objective then of this symposium is to foster digital health research and innovation for promoting the adoption of affordable and appropriate innovative digital health solutions and research that are in the health system. We know that this resources are always limited. So whatever we are proposing should be affordable, otherwise it won't be. And in this initiative, we contribute to the implementation and improvement of the digital health strategy and other health strategies. And through this presentation today and discussions that we assume, we gain more insight on how to harness the power of digital technologies to address the myriad challenges affecting our health system. We know that our health system, whether in developing countries or developed countries, we are facing with a number of challenges, especially the COVID-19 pandemic did expose us. With COVID-19, I think we knew that we need technology than before. And we have seen how technology has helped to address some of the challenges that face many industries, different industries. So the use of technology It's affecting the sector as well as other sectors. So I'm also informed that a team will be meeting tomorrow to further brainstorm on the establishment of a digital health and innovation hub. And the hub will be managed by Muhas Digital Health and Innovation Research Group. It is therefore expected that this is ongoing. This will be done to support staff, students, and interested stakeholders in the digital health related. We know, for example, that artificial intelligence, the way it is changing the way we work, the way we implement some of the activities, the way we provide services in the health sector. So such initiative, such innovations, we need to take advantage of that. But also the ultimate goal is to establish a center of excellence in digital health and innovation at the Muhas campus. And just for information, Muhas has 2 campuses. So there's maybe a campus that's where we are today. But also we have another campus that's much bigger, about 25 kilometers from here. And the structures are being put in place. We have a teaching hospital. Next month we are going to inaugurate the center of excellence in cardiovascular sciences, and other structures are put in place. So all these, I think we need to take advantage of technology, make sure that the system that we have to address our core functions are digitalized. So this center of excellence, it is proposed that it will host digital health innovation research and training lab once. It will also host the medical devices testing laboratory once, as well as centralized health data center. No, data management and data record keeping and dissemination is a challenge. So I think in this we assist the university as well as other stakeholders, the management of data. So Muhas will support these initiatives, and it calls for different stakeholders within the Tanzania and abroad, collaborate with the university in order to achieve these long-term goals. So this program is an example of such initiative. We have people from Tanzania, we have people from outside Tanzania, and I think the aim, as I said earlier, let's share experience, let's share expertise. At the end of the day, I think we should be able to realize the goal of this program. And therefore, we are planning to do this through our unique network of industry, universities, different universities are specialists, government and technology participants, many of whom are presented here today. So collectively, they are already providing through our food in delivering cutting-edge digital health research. I think in the course of the discussion, we should stress the use of research data to improve your plans. So I would like to reiterate my heartfelt appreciation to all of you who have managed to attend this event physically here and those who are attending virtually online. I would like to applaud the organizing committee, and this is led by the director of ICT and members of the Muhas Digital Health and Innovation Research Group for the job well done. We also look forward to seeing similar events in the future, and I think this is the beginning. So let me once again thank the organizers, thank the participants, those who will be making presentations, for making this symposium possible. Especially let me thank our collaborators, our friends, our partners who have come from abroad to join us, our colleagues from the US. Thank you very much for being here today. We appreciate being here. Those who are attending online, thank you very much for joining us. And I trust this will be a successful symposium. And I believe the organizing committee will produce a report with some recommendations on the way forward. What should be the direction? So with these remarks, let me now be clear that the symposium on digital health and innovation 2021 is officially open. Thank you very much.
Thank you, Professor Hannah Nyana, for the acting PDC planning, finance, and administration for this area. About to do the work of things. First of all, acting Vice Chancellor, Professor Kunal Akwa, Director of ICT, Dr. Frederick Kisenge, Chairperson of the Organizing Committee, Affairs Social, the inventor and co-chair, Professor Daudi Simba, facilitators of the Symposium, invited guests, the participants that are present here, but also all those who joined through Zoom. Good morning. My task this morning is very short. It's just to give one of thanks to the guest of honor, the acting Vice Chancellor, Professor Robert Akamo. Allow me to take this opportunity to thank the guest of honor for sparing his time out of the busy schedule to come here and for placing this event. We have taken notes of the guidance, the advice, and the directives that have been given in order to enhance the digital health and innovation. So on behalf of the organizing committee, I'd like to promise the guest of honor that we have taken them into consideration and cooperate to ensure that we implement them in project activities. We want us to pursue vigorously the transformation of digitalization, and this is for the benefit of delivery of healthcare services, but this has to be coupled with innovation. This has to go together. Digitalization, but also there has to be a component of innovation. I take this opportunity to encourage you to link very much with other projects such as the higher education and economic transformation. I know there's a very strong component of also ICT issues, but therefore we could join hands and complement the issues that are covered in this project, who are not covered by this project, could be reflected or covered by the other project. We want at the end of the day to really bring revolution of digitalization and innovation via Muhas. As the Gossip owner commented, we have a campus, we have two campuses in Mubili and Robenzina campus. So therefore, we will then have physical infrastructures there, and therefore we need to make maximum utilization of the physical infrastructures and make maximum utilization of the digitalization in order to bring this transformation from what we are practicing now to a digitalization for. With those few remarks, I once again thank the President, Acting Vice Chancellor, the organizing committee, and all members that have attended here. Thank you very much. Thank you, Professor Said Aboud, acting PDC PFA. We are now requesting for a group picture. The guest of honor will be leaving soon. So we kindly ask you to go outside for a group photo. And then we will continue with the sessions, which will start with the keynote speech process. Thank you.
Can we go to group control?
Hello. Good morning once again. We are back from the photo, and Professor Simba is going to share the session. Which is going to be the keynote speech from Professor Sarah Omala Anderson. Professor Simba, my supervisor, my mentor, and also group mentor, together with Professor Sarah. Thank you very much.
Thank you, and good morning to all. Good morning. Let me take this opportunity to welcome Professor Sarah Anderson from Sweden to come and present to us on the keynote speech. Professor Sarah Anderson is a professor of health and welfare technology at the School of Healthcare, Social Welfare at the Malmö University in Sweden. She's the founder and leader of the research group called Revive Health and Welfare Technology Research Group, which focuses on policies, reimbursement, evidence, implementation, value, effectiveness of digital health intervention in welfare, health, and social care. She leads also several research projects and has published widely. She's an expert and scientist in several Swedish and international initiatives. She hosts monthly international research webinars related to digitalization in welfare, health, and social care, and has founded an evidence-based ecosystem of health and welfare technology. That's a short, brief bio sketch of Professor Sarah Anderson. And with that brief, let me welcome you now, Professor Sarah, to give us your keynote speech. Please, Professor Anderson, you're welcome.
Thank you very much for your kind introduction, and thank you for this conference. I am really pleased to be here, and I'm happy to be invited. I thought I would show a couple of slides. Is that okay if I share my screen?
Yes, please.
Okay, thank you. Just please give me, heads up if you can see it.
Yes, we can see it.
Do you see my PowerPoint presentation?
Slide presentation mode, please. Yes.
Yeah. Okay, very good. Thank you very much. Like I said, I'm really pleased to be here. Thank you very much. And I'll try to talk through things that I've been asked to talk about, and I've been listening to the introduction, which is really interesting. Thank you very much. So let me go to the first slide, which I would like to invite you that we feel being here and being grateful to have this opportunity to connect from where we are. Let's just breathe just like a second or so. Thank you. Okay, let's get started. First, I would like to acknowledge, first of all, Dr. Felix Skomos, who has been able to do this, and together with colleagues who have been able to put together the first Muhas Digital Health and Innovation Symposium. Thank you very much. This is incredible that you are doing this. Also, I would like to thank you that you've been able to set up the Center for Digital Health and Innovation Research Group. And of course, the Muhas as the university and the management who has been supporting this. And everyone who is here, thank you very much for supporting this symposium. I think it's very important to have a meeting place to be able to discuss digital health solutions that can help make life better and also health better for many people around the world, and especially in Africa. So I thought I would just speak about a few things in these few minutes. I would like to talk about opportunities and challenges for digital health technologies to tackle NCDs in Africa, and also talk about why we need evidence-based and informed policies for digital health technologies, and why we need to build research and institutional capacity in universities particularly, and then I'll close after that. I hope that's fine with you, and that's what Felix, you've been expecting from me. So there are so many things out there. There are so many solutions. I just picked a few of them related to non-communicable diseases. And I think when it comes to digital health solutions, of course, we want to understand the early detection because that helps the prevention. So people don't get serious diseases if there is early detection to know that there is high blood pressure, there is risk for diabetes, there is risk for cardiovascular diseases, and then the prevention comes in time and in place. And the next one, of course, diagnosis, because we know that there are so many people with undiagnosed diseases like diabetes and high blood pressure and many other preventable diseases. So the technology can help us to diagnose these kinds of diseases and start early treatment. So that we will be reducing a lot of suffering, but also healthcare costs and society costs. And the next one, of course, is about management, because now we know that we live longer, so people can live with diabetes, but could be managed better with the different kinds of digital health solutions. Like, you know, we can prevent stroke because you can find out that people have atrial fibrillation and you can use just Apple Watch to be able to see that, and many other things to see that you see risks of such related illnesses that can be prevented in time, but also treated in time to reduce suffering and reduce costs. We also know that the prevalence of non-communicable diseases is on the rise in Africa. I think the focus has been mostly on communicable diseases, but we know that non-communicable diseases are actually increasing, and there is a possibility to use technology to be able to reduce those in time, but also to reduce the suffering. So there are so many opportunities we have now. I should say that we are living in the best time ever in the human history. So that's a huge opportunity with technological development, with so much development happening with global communications, like, you know, this kind of symposium. How could we be doing it if you are not in Tanzania right now, which I would love to be, but it's not possible. That we are able to do all the things which were not possible for just a decade ago. We also have the opportunity, especially now we are in Tanzania, that Tanzania have set up a digital health strategy. And this is also for both Tanzania's mainland, but also for Zanzibar. And I also understand that the NCD strategy is also on the way. So that's a great opportunity when we are talking about digital health solutions and how to tackle NCDs. I think we need those policies in place. The other opportunities, of course, is that we do have a large population of young people on the continent who understand the digital solutions, and they are very eager to use digital solutions. I think that's a huge opportunity. And there are a wide range of mobile services. We talk about Silicon Valley in California, but there are also possibilities to create Silicon Savannah, like the one which is in Kenya. And I see that can be extended to other countries on the continent, and many things happening on the western coast of Africa and East Africa, in Southern Africa. So there is much going on right now. And also the international strategies going on, like the Africa Europe Foundation, where we are working on different strategies, including health strategies. They also locally based digital products which can be used in the way that people understand them. There are so many examples like M-Pesa, M-Tiba, and in Tanzania you have the DHI platform where international organizations are coming, you know, so also working together. But also there are these young academicians on the continent who are interested in technology development and who want to find solutions. The international exposure, of course, that helps also. And for Muhas, we have, for instance, a research collaboration going on a project related to digital health technology to prevent and reduce non-communicable diseases, which we are looking forward to see how do we spin this off, starting with Tanzania, but also getting off to the rest of the continent. There are many publications that have been done. This publication is interesting because this is a group of Tanzanian academicians who wanted to see how can we use artificial intelligence based on the models which have been used in other countries. This model was used in South America, and of course I'll talk more about why we need to have those locally based digital health solutions. And this is the artificial intelligence model which was used to detect early detection of malaria. And of course, as it's very important to understand that this can work in Tanzania, because we know that some of these models work in other countries, but they don't work in Tanzania. The latest article that our colleague, Dr. Felix Sukums, is working on with other authors, he's been looking at how much is artificial intelligence being used in Tanzania. What is fascinating is that in his paper, he has found that there are 16 studies in Tanzania which have been used to look at artificial intelligence, which is really fascinating because I think many people don't think that there is so much going on in Africa and people really trying to find solutions to solve the problems and challenges that are on the continent. And I think this is a huge opportunity. And another latest paper which went through what is happening within East Africa innovation experimentation with another colleague who, I think you were here, Tom. Your paper was really very powerful to show what is going on within the East African region. And I think this is fascinating to really see what is happening, which digital solutions are out there. I think there is a lot of opportunities that we can tap into. But of course, there are many challenges that we need to understand. And I usually say that it's good to map the challenges so you know how do we move forward with the digital health solutions, given the opportunities that we have. Some of them I have mentioned, and there are so many others, but how do we mitigate around the challenges that are there? Of course, we have challenges related to digital infrastructure, the internet being reliable, and different kinds of systems not talking to each other. And then we have the health systems, which is a big bucket. Everything from funding, facilities, governance, management, capabilities, access, and the delivery of services. Of course, it's a big challenge. And with that, before we solve that, and then the digital health solutions come in, but maybe could be also a solution to see how do we deal with the health systems. And of course, there is the over-dependence on foreign NGOs and companies. And I think we need more of building capacities and also the capital possibilities in Africa on the continent so that it is more sustainable, because most of the time they are projects, they are short-term, and they are not sustainable for a long time. Digital health is dynamic and involves so many other factors that need to be in place. And of course, coordination is very important. And I think that's why colleagues at Muhas, they are looking into ecosystems. How do we create ecosystems? And that's the discussion we have. How can we start to create ecosystem from Tanzania and connecting with what is going on the continent? I think that's where we need to move. There is so much going on, but it's not coordinated. And many other things related to digital health and health literacy. Why should I care about monitoring my blood pressure, for instance? That people need to understand the risks related to non-communicable diseases, why it is important to know, to detect those in good time. So we start to work with the prevention. And also understanding how digital health works. Of course, I think there is some more work needed to be done there because that is very important when it comes to access of digital health technologies and services related to that. Institutional capacities is very important to build those, starting with the universities, but because digital health technologies involve so many other stakeholders, so that need to be coordinated also to see that we are talking about the same things. I'll just go through quickly here why we need the evidence-based. And of course, on the European continent now it's coming out very, very hardly. I've been in the pharmaceutical industry. You cannot bring a new medical treatment without showing the evidence. But when it comes to technology, somehow we think that we can get away with that. We don't need to show the evidence. So this is really important, and this is what my research group at Maryland University, we are pushing very hard, that we need to know what works, what does not work, and how can we make sure that the technology can be, because you can actually change certain aspects of the technology to make sure that it works, which is different from a molecular medicine. So there is a possibility to make sure that you can create innovations within a technology which is already there. Most of the time when we talk about evidence, of course, we mean that research evidence based on research. But then there is other types of evidence which are very important when we talk about digital health technologies, especially on the African continent, that we need to understand the population, the characteristics, the needs, the values and preferences, and also to understand the resources that are out there. And that includes also the practitioner, the expertise of the professionals, but also the end users. We need to understand the environment, organizational context. So most of the time, the technologies that are imported from other countries to Africa, they say, well, we know that it works. And then they start, getting started with this technology without actually being concerned about these other aspects related to the evidence, because of course the decision-making processes that the policies, the politicians, the payers come also in place to see how do we allow this technology to be in our system. The WHO guideline is very useful, and I would like to recommend it because it can guide us regardless of where we are when we are talking about digital health technologies. Most of the time, the technology comes, especially on the African continent, that, well, somebody, saw that, well, we need this technology, could solve this problem, and then we need also to get the prototype, and we get a couple of people to test this, and then we are ready to implement this. And WHO says, no, you need to go through different steps to know that your technology is ready to be able to scale it up in a larger population. And most of the time, those steps are being missed. I think the most important thing that also the WHO guideline highlights is that we need to know, does the technology work? We need to know the technical aspects, but we need also to know the organizational factors. And then the next question is, how do people interact with the technology? How is the user coverage, for instance, how the response, how the users are going to adopt this technology. And then the next one is about how does the technology improve the process? Because we are talking about efficiency of the health system, the costs. Are we reducing costs, or are we just actually expanding the cost of healthcare? How is the quality? How does it work in the real world? And of course, the last and most important thing we need to know, does the technology improve health outcomes? And most of the time, most of the technologies, they don't go that far. We need to look at that. If we talk about NCDs and technologies that tackle NCDs, we need to address the health outcomes related to NCDs. Policies are very important. There are so many policies on the European region. For instance, also the WHO has taken up the principles related to artificial intelligence. I think that's going to be the biggest elephant in the room, because most of the time we don't know what is in those algorithms and which data has been used. Can we implement those artificial intelligence algorithms on the African continent? Are we sure about how the data is being used? How biased is the data? I think the WHO guidelines on artificial intelligence is really very important. They highlight 6 core principles that we need to have in place. And I think this is really important, and I'm happy that we have some policymakers in this room now. That it's important to think about the ethical principles that we need to address. And also what it does, it gives very clear responsibilities, what businesses, companies should be doing, what government should be doing, and the research also coming in addressing the evidence. And the EU MDR, so this is every technology that will be used within digital health will be required to produce evidence before you implement it. And even after you implement it, you need to show the evidence in the real life. That's what we call real world evidence, because we need to understand moving away from efficacy to effectiveness. So what is going to happen in the African region if you cannot sell your technology on the European market because you don't fulfill all those MDR guidelines that are out there? Are we just going to dump this technology in Africa? How are we prepared to be able to demand for the evidence? I think we need to build universities. This is very important, and also partnerships across different regions. Muhas now is preparing a memorandum of understanding with our university, Marandoran University. I think we need this to build the research capacity at different levels for the staff, for the students, the teaching, curriculums. I think that's the way we need to move, but also thinking into the multi-sectoral partnerships with companies, with policymakers, with academia, with providers of care. I think that's where we need to do. I would like to conclude my talk by saying that several NCDs can be reversed and ended with effective digital health technologies. I think that's the promise we have today. But also, as I said, we need multi-sectoral partnerships that regulators and decision makers need to work more closely with the academia, because the evidence is really needed. Thank you very much for inviting me, and I'm really very, very grateful to see that this is happening, and then we have a platform to start discussing these things and see how we can move forward together. Thank you very much. And please, if I don't know, organizers of the symposium, if there is any space for questions, so we can take those later, and you feel free just to contact me then afterwards. Thank you.
Thank you. Thank you, Professor Anderson, for a nice keynote speech. And if you won't mind, maybe we invite participants who have either questions or have comments to add on what you say, and hopefully you can respond to some of your questions. Do I see questions? Yes, I can see one hand there.
There's one online. There is one online from this day.
Okay. Let me listen to Chair Marwa. Yes. And then we'll go to this.
Good morning once again. My name is Charles, and I'm planning to be taking Professor Sana Anderson for the second time. The first time physically, and now I'm seeing visually. I welcome her tomorrow. But my question or my comment on the artificial intelligence in relation to SCDs.
Can we hear from Ms. Derry while we rectify the technology challenge?
Okay. Can we probably, if you happen to come across a few artificial intelligence, which relates to NCDs, especially now, there is this strong tie between communicable diseases and non-communicable diseases. For example, TB and diabetes. These are comorbidities which are very challenging in Africa, especially in Tanzania. So I just want to get your perspective on this, and probably if there is a current artificial intelligence tools in place which can be used to address these challenges. Thank you very much.
Did you get a question, Professor?
I'm sorry, I could not hear everything said. I don't know whether it's a good idea to write in the chat. I've seen some of the chat.
Okay.
Yeah.
I can just repeat the question that he's wondering whether there is artificial intelligence evidence or tools that can help us to try and address some of the challenges we are having with NCDs, especially when it comes to comorbidities, where you have diabetes going together with TB, which is communicable. Do you have any experience on artificial intelligence or such kind of tools that can help us to delineate the two?
Yes.
Presented the question correctly. Thank you.
Yes, I would say that, of course, with a lot of gratitude and humbleness that, especially in Sweden, we usually call it the maker, the technology maker, that we have a lot of solutions related to that. And also worldwide, there is so much going on the technology side. So there are so many solutions of that type. That can help you to detect and also give you suggestions of what you should be doing in terms of care plans. And some of the work we are looking at, we call it like artificial intelligence and precision health. Somebody asked about health promotion, because what we do is try to do, how do we go the steps backwards before you get even risky factors? So there is a lot of research going on related to artificial intelligence algorithms that help you to detect tendencies to risky factors before even you register as, having a risky factor. So that's where we're going. And then also giving you suggestions, what you should be doing in terms of primary prevention, because prevention, we need to think about, are we talking about primary prevention? Is it secondary prevention? Because secondary prevention is after you've got risky factors you need to reverse. And then tertiary prevention, when you are talking about rehabilitation and all that. So what we are talking about, the primary prevention to prevent risky factors. Let's say that you want to prevent your blood glucose moving from 4.5 to 5. Because we are talking about also which cutoff points are we talking about, that we should not be talking about blood glucose at 6.0, we'll be talking about something below 5. So are you monitoring your glucose? It should be below 5. And if you see it's moving towards 5.5, then the algorithm will be giving it ideas what you should be doing about your diet, for instance, and what you should not be eating. We are talking about precision health, because maybe what is good for Felix is not good for me, because we will be operating differently. It's a big research going on. So I would say that artificial intelligence is going to solve so many, some of those issues related to promoting health, preventing diseases, but we need to understand what is behind those algorithms and how do we make those algorithms being implemented in different contexts, and they will be used in a way that they should be used. Thank you.
Thank you, Professor Anderson. May we now, how do we hear the question from the study?
I think he can hear us.
Can hear us.
The steady, can you hear?
I think it's more of a comment. I can read these comments. Decision making has one clear goal in medicine, the good of the patient. Digitalization of the healthcare environment has made the good of the patient increasingly dependent on the intelligence use of data. The challenge is integrating a wide variety of data from clinical, neurological, laboratory, pathology, observational sources in a way that promotes highest possible quality standard for decision making. We go on saying this must be done while consistently centering patient needs and wishes. Yet complex decisions processes often fail because patient data is inaccessible, too extensive or unstructured. Often these complexities create broad guidelines and errors. A digital platform that prepares a wide variety of data from diverse systems and institutions in a user-friendly, simple, and flexible way could assist in resolving decision making. It's more comments. Then there is a question from Professor Joseph Noor from the University of Oslo. He says, given the different starting points with respect to digital.
Let me check if is getting you. Professor Anderson, do you get the questions clearly?
I'm sorry, I didn't hear the last question. So what is the question?
That was my worry. So I think whoever is asking a question should be coming here. So can you come here to read Desdery's question?
Yes, it's a comment, yeah. I can't see him.
Okay. Yeah. This is interesting. Yeah, it's oh. Okay, let me go. He is saying decision making has one clear goal in medicine: the good of the patient. Digitalization of healthcare environment has made the good of the patient increasingly dependent on artificial intelligence. The challenge is integrating a wide variety of data from clinical, radiological, laboratory, pathological, and observational sources in a way that promotes the highest possible quality standards for decision making. This must be done while consistently centering patients' needs and wishes. Yet, he wonders, complex decision-making processes often fail because patient data is inaccessible or too expensive or unstructured. And often, these complexities create flawed guidelines and adherence. A digital platform, according to him, that prepares a wide variety of data from diverse systems and institutions in a user-friendly, simple, and flexible way could assist in resolving decision-making. Given the different starting points with respect to digital readiness. And he is asking, how do you see the path towards digital health promotion and community involvement?
Very good points. So there are three aspects you are addressing. So it's about the data sharing and data safety. And that's the big elephant in the room. Of course, with artificial intelligence and many of these other digital health technology, there is a lot of data being generated. And even, in Sweden, we are still struggling to see how do we handle the data in an ethical way, and it is safe with integrity for patients and people using there for their own data. So there is a lot of discussion that the person should own the data and decide when to share it and who to share it. And of course, that is related also to the digital health literacy that you also address. Need to understand, okay, which kind of data is being collected, and how do I share my data? Who is having my data? We have iCloud services. Where does it end up? I think that's still the discussion. How do we keep this big data in a safe way that protects the people's individual data? In the guidelines from WHO, they have a big chapter related on data transparency and security. I would recommend that. I had a slide on that. I didn't get time to go through, but it's really very good how to protect data and the integrity of the people. And of course, when it comes to the community, we need more of not only digital health literacy, but also health literacy. Why, like I mentioned before, why should I care about my blood pressure? What does it mean for me? Many people don't know that. And when it comes to technology, which technology can help me? Of course, we go into the evidence and regulation, standardizing which kinds of technology should be on the market. And how do we know which ones do work? Because some of them could be also harmful in a way that they will be showing that you have these huge levels of risky factors and people start to get anxiety. We don't want that to happen. And of course, that will mean that they will need to rush to the healthcare, and then we have overburdening of the healthcare services. So most of those things need to be interconnected. Data security, how do we know this works? What should people know, and what should be recommended from the policymakers? And what research do we need, and how can research and academia come in to support this process?
Thank you. Thank you, Professor Anderson. There is another one that looks similar to the first question that came from Marwa, and this reads, he says, or she says, it's great to hear from you, Sarah Omala. How can we ensure we have digital health solutions that can integrate communicable and non-communicable disease services, as we are seeing the double burden in Africa at the moment?
Exactly. So I think that's it's really very good question addressing that double burden challenge, because we are still dealing on the continent. We are still dealing with non-communicable diseases, infectious diseases, and we still have HIV issues, which are also coming in with the non-communicable diseases. And we know a lot of things going on between the long-term HIV treatments and the impacts of non-communicable diseases. So I really understand that, but I also am very optimistic and hopeful that digital health technology can help us at least to reduce some of those burdens, to be able to detect early, to diagnose early, to prevent in time, and timely treatment, of course.
Okay, do we have more questions from the audience? Yes, I have a question that I think was not responded to, and this comes from Joseph Knoll. It says, given the different starting points with respect to digital readiness, how do you see the path towards digital health promotion and community involvement?
I did hear the first part of the question. I'm sorry.
So sorry, when I was asking, I mixed the two, thinking it was one question. But later I've been reminded that they were two different questions. So the first one was on the issues of security and data access, but this second one is more specific on digital readiness, especially with respect to health promotion and community involvement.
Very good question. And for me, being from the public health side, I usually say most of the digital health interventions that are on community level, group level outside the clinics, we need to think about the public health perspective when it comes to interventions, because that's what we've done. We know that intervention that it don't involve the people that are concerned, they do not work. So that's why we don't see most of the effectiveness when we do evaluations after the interventions. So for the digital health technologies, I think the design thinking model is important for engineers to apply from the beginning. And the design thinking model, of course, it starts like this. You need to understand which group are you targeting, involve the people that are going to be involved in this. Is it a community that has a high risk for non-communicable diseases, or you want to prevent those? They need to be involved in the problem analysis. What is the problem? How can we solve this? So they have to be involved towards providing or developing the prototype. So they are involved in that, because what has happened with some of the technologies that they have not involved end users, they don't work, because engineers think that they know the problem and they know the solution. But most of the time it's the people concerned who know the problem and actually can contribute to the solution. So it has to go back to the design thinking model being part of the solution. But the other one is also about the digital health literacy, that people understand more about what digital health technology is and what it can do.
Thank you, Prof. We have a comment here, and it says, this one I think I already made it. Do you have any additional questions? Yeah. Any more questions from the audience or comments? I see none. Then let me thank you, Professor Sarah Anderson, again for your nice keynote speech that actually enlightened us on digital health and artificial intelligence vis-a-vis non-communicable diseases, that especially in our setting in Africa, we are having epidemiological changes where actually we are having a double burden.
Yeah.
On one part, we have the non-communicable diseases, and on the other part, we have the communicable diseases, which makes it a bigger challenge. And thank you for the advice that you gave, that we need evidence. Some of the things that are working in different countries abroad may need to be researched here so as to contextualize them and be able to tell our people that they work or they don't work. And with the good number of youths that have passion nowadays with digital health and artificial intelligence, I think we are going to have a breakthrough on that. Again, thank you very much, Professor.
Thank you very much. Thank you. I really appreciate this. Thank you so much for what you are doing.
Thank you for your time.
Thank you.
Now, my timetable tells me we are breaking for coffee. Am I right?
Yes.
Yes. So, dear participants, for those who are attending physically, you are welcome for coffee. It is served outside there. And I think we will have half an hour. Yes. And we shall come back. Welcome for coffee.
For those who are online, you can virtually join our tea break. Please enjoy tea coffee break. We will be shortly joining the presentations. Asante sana.
Nimezima ndani yako tena. Sio mkuja. Sawa. Okay, okay. Sawa. Hello? 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 Nimejaribu kumtumia message aliyojibu. Ngoja nijaribu kumpigia. No? Anaamini. Okay, Omari. Sasa hiyo ya press tutadili nayo. Sawa. Hello. Sawa profesa. Okay. Kiasi kidogo ndani haikutumwa isipokuwa walituma kwenye hotspot. Ya najua uko busy na anafikia mwimbili pale kuna siku kama hutaisha Kiswahili nilikuwa nimemuomba nani Dr. nani Christina kwa leo anifanyie ili niweze kushiriki alafu kesho. Okay. Okay. Sasa nadhani mazishi ni sawa. Ya najua kwa sababu shida ya hii sasa tatizo kuomba kwa hiyo nani ibada inaanza saa 7 nyumbani kwake mpaka saa 8 baadaye. Mlisa wanafanya nyumbani. Jana walisema wangeenda kusema lakini naona leo wamekuwa kwa mseta sawa. Na baada ya mlisa sana ndio kuaga. Wanatumia kusafiri sana. Niko huko baada wapi hata nyumbani kwenye siku. Hata wazi ni drive. Yeah, it's true. Namanya apa paling kayaknya deh.
Dani Bengu.
Oke, sama sih. Yes, sorry. Sama kecil. Yang mau bastante la podemos votar. Não? Siyafunga.
Yes, vamos, many parts in the possibility in campaign,
Okay. Simu ndio Morogoro for 2 weeks, mambo ya michezo huko. Lakson
presenting so also working for that with the Center for Digital Excellence and working here in Tanzania in the project for data partnership as a product development. So I will go through this presentation. I will present on the development of the health enterprise architecture and focusing on the benefits and also the challenges. Yeah, so the enterprise architecture is an approach that you can use to manage the complexity of the health systems. So this presentation here, you can see there is architecture drawing, but also the real drawing on this bridge. So if you need to analyze to realize the bricks there, you need to have those kind of architecture drawing, which gives the descriptions of what's required to be done for you to be able to realize the structural drawing that you see there. So this. Yes. Yeah, so the same way in the information systems, we have some groupings of the foundations, like the drawings that we see that map like what you need to see on the digitals. So what is the enterprise architecture? The enterprise architecture as defined by Dr. Monica is a rigorous description of structure of an enterprise, including its components, their relationship with each other, and the environment and the principle, guiding its design and evolution. So the enterprise is including all the components of all the department of the organization or the enterprise. And you need to analyze on how these departments are working together as far as the information technology is concerned. So on the enterprise, Tanzania Health Enterprise Architecture, I was part of the team that developed the Tanzania Health Enterprise Architecture. It was defined as an approach that an organization can use to help align the information system with the vision, mission, goals, and objectives, and help them to determine how to most effectively achieve the objective by using information and communication technology. So you might be able to see most of the people are saying like sometimes like they are in the driving seat proposing the solutions to the health sector. So the enterprise architecture bringing an approach that the solution that we're bringing in as IT people will focus on advancing, focusing on the vision, mission, goals, and objectives of the health. As in Tanzania, still have our digital strategy that taking the vision of the health sector
and transform it to see what we want to see on the digital areas. So here it's driving, it's driven by specific requirement of the organization. So each organization might have its own specific requirements. Maybe there are some organizations that are saying we want to increase the performance. So what should we do as far as the investment of the IT is concerned? For instance, maybe the Minister of Works is, you can say that is our enterprise. So what are the vision and what are the objectives of the health sector? So the EA now come in and see what are the investments or how we can align the IT that bigger picture of the health sector. Yeah, so the EA, as I've said, it's just a combination of the strategy, business, and technology. So here you don't find a mechanism where you don't find a situation where the technology they are just working on themselves, but they are always refining and working together at the strategy level and how the business process are operating. And they are now coming the technology now to support those business processes. So the typical EA, when we brought the enterprise architecture, we need to focus on the current architecture, how the business are run the current situation, and then to analyze what you want to achieve. So now the future architecture, we need to align, as I've said, on the vision of that organization. What are the objectives of that organization? So the future architecture, we need to take into consideration of that, but also taking consideration of other departments. Now, we don't have that expression where one department, or maybe let's say finance, want to do the digital transformation, but that does not consider the other department. Talking on the health area, maybe you want to, one program wants to digitize. I think this one of the program we have in Tanzania, you can say maybe the HIV, they want to digitize, but maybe you go to the OPD, but it's not digitized. So now when they want to do an EMR, come up with the EMR again, it's not connected to the programs, other program, maybe vaccination or TB. Each one has its own EMR as a registered client or a different way. So enterprise architecture coming and see this digital transformation in a general perspective of the organization. So most of the time when we talk about enterprise architecture, other people are thinking of a system, or maybe people are thinking of the architecture, maybe something, the data portability. So that's why I said, what are enterprise architecture? That's something we can also take note. So here is not a system that is to be implemented. It's not a technology. It is not an interoperability tool, or something that can be used by the technocrats. So when you are developing an enterprise architecture, you need to involve the entire organization, especially on the decision level. So because most of the things should require the decision from the top level or involve some finance, so it's not the issue of the technology. Also, it's not the information and data management or configuration management to change management or private sector of automation. It's not and so this is the EA, but EA is rather just an approach or the document that's describing approach where information technology can align with the organization, vision, objective, and goals. So why is enterprise architecture important? Why should we have enterprise architecture? As one of the development of enterprise architecture can be costly, but we need to develop it. Why? So as we increase on, as we want to do the digital transformation across various sectors, as you can see, in every area we are talking of the digital transformation, including the health. So the number of digitalization happening, number of applications just happening to solve the problem. So here it comes, as I've said, to just, as we are doing the digitalization, we have to do from the perspective of the vision, mission, and objectives of the specific organization. So when we talk of health sector, now we are now trying to utilize our digital transformation. We need to look the things and that perspective. Also, enterprise architecture itself, because it put down what you want to achieve or in the information technology. So most of the time there is someone may not understand what you want to achieve. Let's say I want a certain system, but in the end you might deliver something which is not as per the user requirement. For instance, for the area of standard, we need to understand what are the standard we are going to use for exchange of information. So this picture trying to show us, like this is the first picture here, like how the customer explained, we want something like this. But now coming the project leader, this is how we understand it. And then we explain to the analyst or the designer, how the designer is how to understand it. Go now to the programmer. Programmer understands something like this. So you see now that if there is no clear documentation and clear understanding of the entire enterprise of what you want to achieve, you might end up to the end the customer actual need was something like this, but when he explained, someone understand like this. So there is an importance of understanding and documenting what you want to achieve. So that's EA coming and break that kind of there. Also, the enterprise architecture trying to provide a clear view on how business and technology resources support to achieve the organization goal. As I've said, the enterprise architecture coming to see it's not about innovation, but how those innovational technologies will help to move forward the vision of the organization. And also understanding of the structure and business processes and business system and infrastructure and how they relate to each other. So the person who is developing enterprise architecture need to understand the structure. And sometimes they say most of the time, people who are within the organization will be in a better position to develop the enterprise architecture because they understand more business part, the processes, and the strategies, so it will be easier for them. Also, reach common understanding, as you saw in the previous speech. You need to have a common understanding and alignment. Also, you have to prioritize decisions, prioritize and decide which things to do and which order. Otherwise, you say do the right thing. But also governing the change and doing the things. So this picture I see like there is an organization vision. Organization is a vision and organization alignment. So you can see you might have a vision, but if there is no alignment, then your performance might not be well. Because like Jim Cohen said, great performance is 1%. I mean, vision for great performance, we need to have a vision. You will contribute 1% and 99% is alignment. As you can see here, if you don't have a vision, someone will be investing something which does not contribute the bigger vision of the organization. So again, another area of importance of enterprise architecture. Looking at this picture here, this is just like a city where there is no plan, example, don't have a plan. Everyone is doing its own investment, and they are thinking from the perspective of their own department. For instance, in the health sector, maybe every program is thinking on the investment on the digital area, like their own thinking without just understanding what are others doing and what are the vision, general vision of the organization. So here you see a house has its own electricity, has its own water, has its own security guard, has its own type of gas. So everyone needs to have its own security. So if there is no enterprise architecture, this is how these things they are looking from the IT perspective. But if you are and the purpose of the plan, let's say we're talking of the same example, it is just to ensure everything fits together and people can share the resource. So enterprise architecture now coming to help for that area of sharing the resource. So as you can see here now, there is these steps, water is shared across this house, electricity is shared, but also they have to share the security guard. So the same, talking to the enterprise architecture, the resource is shared. As I've said, previous example, for instance, if every department within the hospital is having its own system, and they're all registering clients, they are not sharing this information. Someone will come for a treatment of one disease will be registered, then go to another disease will be registered. So we're not sharing the resource. Maybe one person can do the registration and they can get the service across. So the enterprise architecture is trying to resolve that kind of thing. So there is a shared services, as you can see there. So you can see from the health sector, we have the enterprise architecture. The enterprise architecture recommends there should be the information mediator, that's how we call it, health information mediator here, but also there is these shared services, technology, facility registry, all these current registry, shared registry, or the administrative registry. These are the information that will be required by almost all the systems that you are developing. So they have to be, this information has to be shared so that you have the continuity of care, but also managing the resource well. So in the health sector, so Dr. Manika wrote an article there, Enterprise Association of Enterprise Architecture, after the goes through providing the rationale of the health system. So the goals of the enterprise architecture still emphasizing on the benefits. So in the typical way of the design of the enterprise architecture, we have 4 domains. We have the first domain will be the business, that talking about how the health or the process will be operating in the health sector. That is when I say it's the function architecture. In other words, you can hear the same business architecture. So business architecture or function architecture, we focus on the principles, objective, policy, function, how they, what are the vision of the health sector. This now in the function architecture, now we have those experts from the business area providing their vision, how they would like the process to be. Now, the other part is of the technology. So technology is comprised of data architecture, application architecture, but also the technology itself. So the technology now, the information architecture have things like data, how the information system should support the objective. You can see everything is pointing to the objective of the organization. And also the infrastructure, things like how the network should be, how the phones and computers should be. Now we want like to digitalize all the hospitals in Tanzania. We need to have a common understanding like how the infrastructure should we are going to use. That is, are we going to put a land in all health facilities, then those facilities interior, or we're going to have the wireless, so we're going to use tablet, or because we have a system, we are going to use a desktop everywhere. Is it applicable? There are some areas where there is no electricity. So these things has to be well understood and documented for your enterprise. So these are the steps that you can take to follow the enterprise architect. Firstly, you need to initiate the process. Now here you define the scope. So in initializing the process, now you need to ensure the sponsors are understanding or the top management understand what you want to do. Because most of the time, the enterprise architecture will ensure that maybe some of the system will be retired, or some of it, you will propose some of the changes so that to be able to achieve the vision of the organization. So the management here will need to be involved, like say, identify the stakeholders and establish the common vision with them, what you want to do. And the next step now is about the process or the function, the business architecture. How are the processes being performed? What are the functions of our organization? So you define those processes, and then information system. What are the information system current supporting these business processes? And also you define on the data architecture, like the data that we have, the standard that we have, and how are the data being shared across the organization. And the other thing is the policy and guidelines. These are very important because might have people maybe are using the paper forms. Then in your target architecture, you're saying we're going to digitalize. What are the policies of reporting? Are they going to be the same? If you are saying every 5th of the month, health facility need to report or send the report, this is a paper. Now you have the digital system. What should be there? Are you going to have the same date of 5th of every month? So these are the things which enterprise architecture insists. When you are not going to develop a system itself, but also looking from the guidelines and policies, how are they going to change? And this is something very important to the system that you are to the digitalization as you go on in Tanzania, looking on these policies and guidelines. Also, to validate with the user what you have developed as a system for business architecture. You need to go and validate. Look at if they will be valid or work. Then you develop the target architecture where you think on how you want this thing to perform. Because at the baseline, you see all the challenges, you see all the gap, and then you see all the vision. What are the vision of the organization? Then target will focus on ensuring addressing those kind of gaps. Like I said, identify the gap and you see how you address those gaps, how the system will operate to support the vision. And identify the common function, processes, and information entities, and identify systems that need to be retired. So this is also important. There are some systems that you need to be maybe retired because you might have a number of systems which were developed without thinking with the other system. So this kind, as I said, this kind of decision also need to be involved with the management. That's why the initiation process is very important. And also here you validate with the user. Then also most of the important aspects also the governance part. Otherwise, you might have the document that describe your architecture but is not implemented. So the governance, we need to identify the governance team that will govern the enterprise architecture decisions. So Tanzania will have a subcommittee for enterprise architecture. Those people will be overseeing and proposing things that done. And also orientation of the year spirit. So people need to understand, especially the management at their level, to understand what are the big picture on the enterprise. Then you have the transition. You may not go in one day and change everything for the enterprise architecture. Might not be possible due to the availability of funds, but also the technology and things like that. So you need to go and step, have that kind of plan, the roadmap to decide the enterprise architecture. Also, lastly, to simulate the information. So this was just as experience for the So what are the challenges? What are the challenges for implementing enterprise architecture? So these are some of the challenges I find. So one of the challenges is lack of understanding of the SCORM concept. As I said when I started this presentation, some of you maybe might say this is a system. So when you present and you want to implement to the maybe management, they know enterprise architecture is a system. They might not be able to implement the enterprise architecture. So they understand that people have to understand. Also, lack of realistic thinking. So if you are thinking from perspective of your department, so now that is against the enterprise architecture. So people need to think holistic and engaging as much as possible the entire stakeholder from the organization or the enterprise. Looking at here as a technical issue. So enterprise architecture is not a technical, as I've said, it has 4 domains. One of them is the business architecture. So the business is not the issue of a technical. People from the business, you need to identify their function. So the health sector may be people from the first need to be involved in the enterprise architecture. So when NRI you see the development of the enterprise architecture, and there is only IT that EA might end up in favor. Also, weaker governance process to enforce. So, as in the steps that we highlighted, there is a governance of team that will be overseen, and also they must have a proper mechanism to be able to enforce. Also focusing on the legacy issues instead of future, people might not be able to change. So now managing the aspect of the change. And the other thing is also getting into physical in the process. For instance, people start developing the enterprise architecture. They are starting looking at the system without the actual system without looking at how the process will be. Now that implementation at the end of fail. Last year is focus shifting from business to technology. If you think of the technology only and forgetting about the business, that will be an issue. Yeah, so Tanzania, there is an enterprise architecture. We found that that is the digital library. So it's uploaded there. Yeah, so the focus is client. As you see here, we presented at the beginning, is focusing on the users, the client of that specific system or the technology that you want to use, and not all the new technology. Thank you very much for listening. Thank you also for quite a nice presentation. We present Nico's perspective. So hopefully you'll be able to respond to questions that are directed to Dr. Manyima. So the floor is yours. Participants, those who are here physically and those who are with us speaking. If we can start with those who are here physically. We have heard about enterprise architecture. Quite good details. Maybe while you're still digesting your questions and comments, I may want to bring the presenter to respond to. I didn't hear about monitoring and evaluation. I'm a monitoring evaluation person. When you have monitoring and evaluation of these enterprise architecture, whether it is functioning or it's not functioning, whether you need to improve somewhere because of challenges that you have met, that is my immediate question. Yeah. Can you please?
Maybe use that.
Yeah, easier. We should come with just
come
come
with
with
my
Awesome. Thank you. Thank you for a very good question. Yes, it was not clear in the presentation, but from the perspective of the implementation of the interpretation, the monitoring and evaluation is very critical part, and it has to be done. And based on the structure of the interpretation, if you have the governance maybe committee who will be overseeing that implementation, that should be something they can be able to see how they can be able to monitor and evaluate the progress of the implementation, and also be reporting that progress to the management, because the implementation of the enterprise architecture requires a lot of input from the management, so that they can be able to support the change that was. Remember, here we are talking, we have a certain architecture, and then you are saying you are going to a partner target architecture, which will require some sort of resource, maybe including training people, including investing in a number of technologies. So that monitoring and evaluation is very important. Thank you. Thank you very much. I can see a hand there. Ladies.
Thank you for your presentation. So, you were saying in the slides that as a member, we already have overall representation. So my question is, from the what the other condition systems that we have now, assisted for regional district, are they all structured towards the common technology structure towards the enterprise architecture. To strengthen the use of the
Yeah, for those who are with us initially, the question was, does the health system, the health information system that we have follow or addresses the enterprise architecture that we described here? Please.
Thank you for good questions. Yeah, the question was if our health systems from dispensary to the national level follow the enterprise architecture. So, as part of the enterprise architecture, we're focusing on the number of issues, depending on the level of scope that you want to go. As far as I know, from the nearest enterprise architecture was focusing on providing those guidance on the standards to be used for different systems on the health sector, but also focusing on those process of digitalization. So, responding to your question, if all of them have been implementing what is suggested from the enterprise architecture, that is not yet, but I think most of the things are which I know, it is in the process of aligning with the enterprise architecture. Looking for the things like health information engagement, exchanging of information. So all these were kind of proposed, but we are not yet there. We are implementing. And recently, the governing committee was started, and they have started doing some assessment of what is currently seeing like how can we go into that target architecture.
If I may add to that, you gave us the steps in the development of enterprise architecture from step 1 up to step 60, for example. So based on that, where do you think Tanzania is operating?
Thank you. So I think from the step that shown here, we have already we have enterprise architecture, and then we have that step of the governing committee. They have, what I know they have done in the first meeting. So we are around there forming the governing committee.
So stage 1.
Not stage 1. There was a stage if the
is it possible to share
my presentation? Those that we forget. The first step was the initiation, and then the work with the business, then the target architecture, then we went, the baseline architecture, then we went for target, then governance. That is the step. Yeah, so that's what the step. Yes. So initiation of the process that was done. So the baseline architecture defining what is the architecture that we have currently, that was done also. And developing of the target architecture that is done. And I think we're around establishing the governance structure and planning for the transition. So that's thank you. Any more questions from the audience? Do we have any questions?
Yes, this is.
Uh-huh.
Can you please clarify the system relationship between the enterprise architecture and the health information mediator? Is the health information mediator kind of a component of as it implemented the enterprise architecture, or what is the relationship?
Thank you for the question. I can see that it's a very interesting question. Thank you for a very good question. Thank you. Most of the people might talk about health information mediator as an enterprise architecture. So even in the enterprise architecture, there is that kind of there is information on how the system can exchange information. So that is the component within the enterprise architecture, because the main goal of the health information mediator is to see the system exchange information, but also improving on those issues of securities. So the enterprise architecture has to ensure focusing on how the system should interact. For instance, those convention systems, we need enterprise architecture would say we might have a client register. We should have shared best record. We should have product register, let's say. So those are the components within the enterprise architecture. But enterprise architecture itself really comprises of the business architecture, which is not the IMO is just one part of application architecture. You have the data architecture showing you what are the standard of data that you use when we exchange information. You see information like a file standard, which is kind of proposed when we exchange the health information, partial information. Thank you for right good response.
From the data ICT. The next one ICT is your hands. Mr. Inoku, you have raised the hand. Do you have a question or a comment? Mr. Inoku, if you can hear us. I must share this.
Hello.
Hello.
Can you hear me?
Yes, a moment, please, while I'm winding up the previous session. I can see that there were no more questions, and thank you on behalf of Dr. Manika for presenting to us the enterprise architecture. It was quite enlightening, especially for most of us who used to confuse it with IT technology. Having said that, let me now welcome Mr. Ilomo, who is the Director of ICT at the Ministry of Health in Tanzania, who is going to present to us about the Tanzania Health Strategy. He's going to give us the priorities, progress, and challenges, and hopefully you will wind up with some recommendations. With that, you're welcome, Mr. Law.
Thank you very much, moderator. Good afternoon, everybody. Yeah, my name is Silvanus Lobo. As you see in my presentation, I'm currently a Director of ICT, Ministry of Health. I'll be presenting today on a journey for Tanzania digital strategy which is of June 2019 to July 2024. Actually, Tanzania is among the countries which is doing good in deployment of digital health systems. And in my presentation, I will consider a summary inclusive to introduction. Basically, I'll try to show out a situational analysis for previous strategy, because basically what you find here is a current strategy of 2019-2024. And basically we had a previous one of 2013-2018. So I'll try to take you through on a situational analysis for what has been achieved, what has been not achieved, what are the challenges also. But also it was a point where we have got like a lesson on coming with a new strategy of 2019-2024. And also I'll try to dive on our new digital strategy of 2019-2024. Sorry, not 2021, that's 2024. Sorry, very sorry. Basically, for the previous strategy of 2013-2018, our achievement was like 55.5%. This is due to plan targets that were achieved at different levels. Some are full achieved, some are partial achieved, but some are not achieved, as you can see from the distribution of percentage of what has been not achieved, what achieved, and what is partial achieved. You can see that we have achieved like 13.3%, and what is partially achieved like 42.2%, and what was not achieved was 44.5%. Our ES strategy of 2013-2019 achievement as follows. Like we were able to, we were successfully deploying a national backbone, a network in the government. Also, we strengthened the scale up of HMIS data, which is DHIS2 digital systems. But also we were able to deploy a plan-led system with the collaboration with the PORAG we are doing together. Also, the national rollout of electronic logistic management information system. Also, EIDCR integrated those diseases which are supposed to be reported immediately as they happen. They're using the system called EIDCR. Also, we are able to deploy health facility registry. And NSMIS, which is a national sanitary. Part of at the service level, point of service level at the facilities, we're able to deploy electronic medical records. Gotomis was deployed. Basically, this statistic of 383 facilities was for the previous strategy, not for the current strategy. So if we come to the current strategy, we see that there's a long incremental in that 383 facilities. Right now, we are approaching to 1,000 plus facilities for Gotomis and aftercare deployment in our healthcare provision facilities. Also, we are doing some improvement in telemedicine infrastructure at the facility level. Again, also we used to deploy, disease-specific digital system like CTC3 and CTC3 database for HIV and AIDS and TB and the leprosy registers, which is called ATL. Also, vaccination information system has been country deployed, and Tanzania immunization register, MHealth platforms, reporting and client feedback digital systems, national health insurance and e-claim solution were also deployed at the facility level. So these are some of the success that have been achieved for the previous strategy. As you can see, as I said that in the previous statistics, some are full achieved, some are partial achieved. For example, installation of local area network and the national ICT backbone. Still today, we are continuing with this exercise, because as we know that it costs a lot of money to deploy such kind of initiative in our facilities. So the process continues. So we are trying to increase as we are getting some resources to do these kind of activities. But also we face some challenges on our previous strategy, like reluctance of turning legacy to paper, legal systems. Most of the healthcare workers are not that much conversant with the use of digital system. So most of them, they are trying like to ignore, or maybe sometimes they don't want to use this digital system. They still want to use a paper system. So this is the kind of challenge which we've been faced, the existence of multiple systems which are not integrated. Also, there was an reliable internet connectivity, and electric power also was kind of a big problem, lack of time support, because as we know that for the previous started, like we are ICT officers, people for providing support at the facility level, region level, and the district level, where we are not enough as we are talking of today. Also, shortage of funds and resources to make sure that we are supporting this, initiative like health workers and whatever. And also skills and computer use, as I've said for the first point, that healthcare workers with low knowledge and skills on the computer use. So sometimes people may ignore because of lack of knowledge, or may ignore because of he don't want to use this. So they are kind of challenge that has been faced with the deployment of the last strategy. But also shortage in ICT facilities, healthcare workers, basically. That was the last point. Shortage of ICT facilities, healthcare workers. Also, that also it's a big problem. So these are kind of challenges that we have been facing for the execution of our strategy of 2013-2018, which is called the e-health strategy 2013-2018. But also having e-health strategy of 2013-2018, it's not something which we didn't gain anything. We gained some issues that we count as lesson learned for us, maybe to improve for the coming strategy. These are some opportunities for improvement for this current strategy that we had right now. Like we see, like including some political leaders is something key, because they are the one who are driving most of the issues. So we found like including them in our deploying of this kind of initiative is something very helpful. Capitalizing and learning from the past experiences. Basically, we have learning come from different perspectives, and we found different issues happen at different areas. Those are like something like learning experience for us to make sure that we are improving the current strategy. Availability of guiding documents is one of them has been presented. You see, we didn't have, by the way, when we are doing this previous strategy, we didn't have health enterprise architecture. As currently, you can see that now we have an enterprise architecture, which is now functional in place. Also, availability of local and international vendors, developers, or health solution expertise also was one of the area that we see like could be an opportunity to the improvement of the next strategy. Again, the financial and technical support from the government, implement partners, and others also could be something key that we could be adapt so that we can do better to the coming strategy, as I've said. So from the years strategy 2013-2019, we came to digital health strategy 2019-2024. This is the approach from previous learning lesson. Now we come to learn there are some issues that we should consider in developing this new strategy, which is now called the digital health strategy. But the previous one was called the e-health strategy. So this was developed through analytical and participatory approaches. We make sure that we consider both areas that we could have a touch in a health sector or another, to make sure that they are providing the comments, advice, and everything that it could be helpful to boost the quality of the document that we're going to produce. Also, involvement of situation analysis of the previous strategy, something key, and also informed by the assessment report of 20 years strategy of 2013-2018, but also consultant digital investment recommendation roadmap. Basically, for the previous strategy, after developing the strategy, also we developed something called investment recommendation roadmap, which is a costed action plan for the previous strategy. So that was one of the resources we are using to make sure that we are improving this current strategy of 2019-2024. Also, guidance from WHO, global strategy. Also, it was something also help us to to make sure that we align with the global initiative where we are supposed to go with. Again, also align with the national policies such as National Policy of 2019, National Policy 2016, and Tanzania Development Vision 2025. But again, also among documents or mother document of the health sector, which is called a National Health Sector Strategic Plan of 2015-2020, also was considered as one resource to make sure that we are using this current approaching of developing a new strategy. Approach was a consultative workshop, and so we consider disciplinary stakeholders, ministries, training institution, department, implementing partners, and also TWG, those technical working group which working under the Ministry of Health, but also endorsement by the management of the ministry, and the digital strategy of 2019-2024. Basically, our final was launched by the Prime Minister, Honorable Kassim Majaliwa, after being completed. So what is the content? What is the strategic direction now with the strategy that we have? What you see that the vision, mission, but also our strategy has got guiding principles, strategic goals, and strategic priorities. Here you can find strategic goals, strategic priorities, and initiatives that have been addressed in our digital health strategy. Here are the strategic goals: strengthen digital health governance and leadership, standardized information exchange, improve client experience through efficient provision of quality health services, health providers and managers empowered to take evidence-based action, sustain the availability of health resources. So these are strategic goals of our current digital health strategy. Also, we got like strategic priorities. From the strategic goals is where we derive and come with the strategic priorities. Now, these are the considerable strategic priorities, like area delivery points, area of improved health workers' competence and provide specialized care to underserved facilities, and also the area of health behavior through the relevant health education and information. These are strategic priorities that has been grabbed from the strategic goals. Also have a seamless and secure information exchange, evidence-based action, control and management of health commodities, improve management of human resources, improve management of financial resources, strengthen disease prevention, surveillance, detection, report, response, and control, which now you can find most of these are now in place, like areas with financial resources. We have got FAST, we have got GPG, we have got several digital systems. Like number 5, you can see we have got, to enhance seamless and secure information exchange. We have got health information mediator, we have got Muungano Gateway. So there are some initiatives which are currently running, which are tallying with what we address these strategic priorities in our current strategy. How and what are the back end for the successful of the strategy? Basically, as I've said before, strong governance and framework for digital health was key. Resource mobilization framework, which is the investment recommendation roadmap, and also change and adoption strategy, research, innovation, and development in digital health. Also, monitoring, evaluation, and learning also is something that has made that to be successful and in this current digital strategy that we have. Here is a governance framework. You can find a technical committee, sector-wide approach, which is working with the National Digital Steering Committee. Also, you can see that we have considered with the Health Facility Digital Committees, RHMT, CHMT, Institutional Digital Health Committee, and there you can find there's M&D and ICT TWGs. Also, there are some derived task team to make sure that they are feeding the M&D and ICT TWG so that we can have a clear result of what is going on at the ground level, at the RHMT and the CHMT level. Asante sana. I beg to submit, Chair.
Thank you, Mr. Yomo. Thank you for your quite informative and nice presentation on the, should I call it, digital health strategy. I think that should be the first question to you, or at least to elaborate to us who don't know the difference. Why not looking for people who have their hands up? Yeah, I can see one there. Two. Yeah, this I think invites. So let us start there. Oh, what mechanism should we use? Because I noticed I have to repeat the question to the presenter.
Yeah,
talk from there.
The wireless mic is not very much functioning.
Yeah. So may I welcome you here so that you just ask yourself your question straight and I don't have to repeat.
And the next person can sit here.
Yeah, the next you may come forward.
So that we will say same time.
Sure. Produce your name and give your question or
Okay, thank you, Mr. Silvanus Gomo. My name is Pan Ayobsen Paraje. I'm a medical student at the University. My question is, I don't know the position or contribution of the Ministry of Health to private and young innovators in DHI, and also their contribution or their support to student professional organizations which participate or advocate in DHI. Thank you.
Okay. We have another question. You will then you will respond to Bob.
Thank you very much for the opportunity. I have two questions. One of them is what my fellow has asked. Now, my second question is about data. As you know, with this digital transformation, data is the backbone of this transformation, and the government has been doing a good job in collecting this data daily. But how is this data made available to third parties, people who are coming up with innovations, they keep this data? How is the government ensuring that this data is available? For example, there was a challenge by UNFPA. People came with good ideas on how to make this data available to third parties.
Sorry, sir. Would you please come again? Sorry. I was like a network interruption.
Okay. My question was about that. So the government has been doing a good job of collecting data, especially in the health sector. But how is this data made available to third parties, to people who are coming up with innovations, people who are coming up with good ideas? How does the government ensure that this data is available in a user-friendly way, in a way that people can interact with the data? And how is the government flexible to allow innovations with this area of data? Because data is, I can say, the backbone of these innovations. Thank you.
Okay, we have another question.
Morning. My name is Swara Kadika. I have one question. If I hear correctly, you mentioned something about medicine infrastructure, but the question is not really on the medicine infrastructure, it's about the policies governing the national medicine. Currently, we have a lot of the innovation in medicine, especially the concentration. So my question is, do we have a strategy over this area? The second point is about
Kabika, would you please come again? Sorry.
The question is if we do have the medicine strategy or guidelines for this, because currently we have a lot of the innovation in telemedicine, especially in consultation. So we have the strategy, we have the guidelines. That's the first question. The second one is about the data storage. Recently, I have my attention that most of the health facilities, they keep on directing data. They don't have a documented data. They delete data so many times. So the question is, do we have any standards or guidelines on how an institution is supposed to store medical data? And keeping in mind, for example, patient information records, some of the data results, critical information, so this kind of data.
Sorry, Kabika, will you please light your question, because I hear a lot of echoes. So I reach a point I can't hear you, and sometimes you disappear.
Okay. While he is writing, I can explain it to you. Basically, Toa is asking about whether the ministry has policy or guidelines or strategy for telemedicine. And in addition, is there a policy in terms of data storage, particularly on diagnostics? That is, did I present the question?
Yeah, I get it. I get it now. I get it.
Okay. We have another question, and then I'll give you opportunity to respond.
Thank you very much, Mr. Saito, for your presentation. My question is just out of curiosity. You have presented the strategy of HI, but my question is how this is realized in our local health facilities. How one how is being realized there, because we used to have strategies, but at this very moment, we want to see them being realized in our health facilities.
Okay, now I give you opportunity to respond to the 4 or 5 questions. Please, you're welcome, Mr. Law.
Thank you very much, Mr. Moderator. Basically, I've got, and also thank you for participants for your questions. Basically, they are good questions to make sure that we are expanding our each other ideas. I'll start with the question from somebody, Faraja. I mean, if it was clear, he asked how the strategy is supporting young innovators on digital health. Basically, as I've said in my presentation, a preparation of this document engage different multidisciplinary stakeholders. One of them is COSTECH. So we are trying to consider in every area to make sure that we provide an opportunity for young innovators to make sure that they are contributing the level of efforts in improving healthcare services. So COSTECH is among the organizations that have been considered during the preparation of the document, but also higher learning institutions. Also, we have used to consult them several times so that to make sure that our students with access to with the capability to digital health, I mean research and whatever, they are part of the implementation of this strategy. Also, I got a question number 2. It was how the strategy is accessible and available to innovators if I'm sure of it, or if I'm not sure of it. I mean, he asked about the strategy accessibility and availability to young innovators. After launching the strategy, we tried to make sure that Sorry?
Yeah, I think
Hello?
the question well from the other participant was access to data. They have they have passion for innovation, and through that they need data which can guide them. And I think they find it difficult to access it. And I think the question was directed on that.
Okay. Sorry. The second question also is access with data. So when we developed a strategy, a digital health strategy of 2019-2024, we came with some several guidelines to make sure that they complement to the deployment of the strategy. So when you want to access the data from the ministry, that can be possible, but you should abide with what guideline called Health Information System Guideline. We have a Health Information System Guideline, which provided steps on how to go about so that you can have access with the data. There is a guideline which is working with that area. So I think that is clear with the data accessibility, but also even in strategy, one of the strategic goals also address with the data access. So you can see from the strategic goal that they have been. Question number 3 was from Mr. Kabika, if not mistaken. And the question is about the policy. Yeah, we have a sectoral policy, which is called the Health Strategic Plan, which is a sectoral policy, where all other initiatives, whether it's cure, whether it's prevention, whether it's digital health, whether it's quality assurance, whether it's whatever,
we are missing you again.
You have to abide and make sure that you are. I mean, regarding with the data storage policy, basically here we are guided with the policy which is provided by our authority, which is called the IGA. Basically, we are trying to, we should abide with the policies which are provided with IGA, that data storage has its guideline. And also, I think if we develop a digital system, I mean, data storage should be in a country and in local managers' infrastructure. So you can see now we have where most of the government system are hosted there. And these are kind of instruction provided to all government institutions to make sure that all digital systems developed whether in country or adapted outside the country, they should be hosted in government-owned infrastructure. So we have that kind of policy which is dealing with the data security, data storage, all of them they are in one guideline. Again, the fourth question is how strategy is realized by the health facilities. Basically, if you find in my presentation, one of the slide addressed with the deployment of electronic medical records in your health facilities, I just provided example there where we deploy Afya, we deploy Gotiomis, some facilities. So that is basically the realization of the strategy. Take strategy into action. I think that is a big realization of the strategy. So we are trying to make sure that we are working close with these people from the point of service delivery, because if we are not considering them much in what we are doing here at central level, then we try to pick some stuff and put it to them without considering them from the first point of planning to the end point. Then they will be like they'll be getting like no ownership with it. So we are trying our best to make sure that we are considering in every part that we are doing as ministry in collaboration with TAMISEMI. Also, I found some question in messages which have been sent by different members. ELC to digital health strategy. Digital is more comprehensive, which include aspects of ICT and the data system. I think here NEM also is trying to provide some comment with, or to comment on some of the questions that have been answering here. Thank you. Question, we will compile all the questions, ask present to respond. Okay, this I think Dr. Sokums was provided like a guidance. Here I have from Rashidi. Thank you for the nice presentation. My question is, this is from Ibrahim Simiu. My question is how telemedicine infrastructure deploys as substitutes to face-to-face consultation for continuity of care during pandemic in Tanzania. What plans are in place to scale up telemedicine service in the country as a contingent to coming health crises like COVID-19 in future, given that telemedicine services were introduced a while back in the country between 2005 to 2010, if not mistaken. Thank you, Ibrahim, for the question. Basically, we are ministry, the government through Ministry of Health is trying its best to make sure that we are complementing with the deployment of telemedicine services in our country. As of current, we got some resource that we will deploy telemedicine infrastructure and solution and training in like 20 regional referral hospitals. I think we are going to deploy the telemedicine services with infrastructure, like as we have mentioned in the face-to-face consultation. So that's kind of video call technology or whatever. So we are ready to consider that in our plan, and reaching maybe July next year, you will see like most of the hospitals, consultation from these regional referral hospitals to national hospitals will be via telemedicine. Also, his name also tried to add strategies available on digital library, but also available in the ministry website. Again, I got a question from Lars Weiderman. Thank you very much, Mr. Elomo, for your presentation. I have two questions. One, mention reporting and feedback client is an achievement for health strategy 2013-2018. Could you elaborate a bit that? Does it include feedback from healthcare professionals using digital solution? And if so, which digital solution? And what have been the key learnings? Okay, let me start with his number one question. Yeah, for sure. As I've mentioned in our previous strategy, we are able to deploy like a digital tool that's allow clients to send their feedback regarding on the service that they have perceived from the facility. So this like a digital tool which is using a mobile technology, like how you call *1234, like M-Pesa, Tigo Pesa, whatever. You just call like USSD technology, where then you lend it to the platform, you provide your feedback, then the feedback are being populated to a central database where these can be analyzed on a different perspective, like who send the feedback. Are they people under 18? Are they women's? Are they men's? Or pregnant women, children? So it depends on a need of analysis that is requested by the ministry. I mean, you are business people users. So here the tool is working as I'm talking right now, and I've been deployed, and we continue to deploy. So we can go. We want to go it countrywide. So everywhere that people, when getting service, they'll be able to provide their comments on the service that they had from the facility. Also, Lars, your question number two, you say that I also mentioned an ML platform for enhancing health promotion as an achievement. Could you elaborate a bit that include the targets, audience it's for? Thank you. Yeah, for sure. We have different health platform in our country, especially for pregnant women and children, to make sure that we are alerting some pregnant women to make sure they are attending the full visit at the facility. Because as we know that when the women get pregnant, they have some visit to attend at the facility. So this kind of health platform tools, they're trying to alert them that you have to go second visit on certain date, you have to go your third visit on certain date. So we are using health platform in that kind of aspect, but also health education, we do it because we try to provide some messages which are key to education, like sanitation, hygiene, pregnant women, what they are supposed to do, what they are not supposed to do, what they are supposed to eat during pregnancy. So they are, according to different perspectives that they have been provided with the business people, then we do tailor it in our digital systems. Also, I had a question from Rashid Goz. Thank you for the night presentation. I have a question. Why you changed the strategic plan from e-health to digital health, and how that the digital health is going to overcome the challenge faced from e-health? Basically, we try to go with the term, because globally now most of the people are trying, or most of the countries, they are trying to use the term digital health and not e-health. So we found, like, also we Tanzania, we are not an island that we will not be interacting with other countries. So we found like it's better to have that common term of digital health in terms of e-health. Also, you said overcome challenges. Yeah, for sure. We are trying our best to make sure that we are going to overcome these challenges from the previous lesson learned. And as I presented for my presentation, those lessons learned are the one which will make us to make sure that we trigger the challenges early as possible. Because our first strategy, we developed it with very ambitious goals. So we didn't find some of the goals will not be achieved because of our lack of infrastructure, lack of connectivity, lack of human resource, lack of know-how. So these are kind of stuff that have been made us to come up with the World Digital Health Strategy.
Thank
also,
you.
Mr.
Sorry, Mr. Yomo.
Yes.
For the sake of time, and we are having other presenters on the queue,
Thank you.
We are going to, if you can respond to the questions in the chat list, we will read the questions and the responses to the participants after some time. Let me take this opportunity to thank you for your responses. Although there's one burning question, there's someone whom I'm told is really wanting to hear from you with regards to standards, what you say, standardized exchange of information. She wants to know what action have you put in place to ensure that that standardized exchange of information is operational. And another small, just to add to that, is you talked about telemedicine. She wants to know the status in the country.
Thank you, Mr. Moderator.
Answer those, and I think the rest you will give us through writing, and we'll read to participants. Thank you.
Thank you. Regarding to our strategic goal with the information exchange, standardized information exchange, what we do right now, we as a country, we come to realize that we should develop system with the global standards so that they could be able to exchange data from each other. But we found like exchanging one-to-one or peer-to-peer data exchange, it will make us late, or it will make us with a lot of complication, because you find there are like 50 or there are like 20 systems, and each could make sure that they are exchange data to each other. So what we did is introduce an interoperability layer where a digital system if want X, maybe data X from a certain system, that other system will just push that data X to our interoperability layer, which is called the health information mediator. And then M system or P system will pick up that X data element or that X indicator from the interoperability layer, rather than having rather than having P, M, and Y exchanging one-to-one. You find that like there will be a lot of data exchange of peer-to-peer or one-to-one system. So that the health information mediator, it helps us to make sure that we are doing data exchange centrally, and it's easy to control. So that's why we come up with the interoperability layer. But also the status with the interoperability layer, for now we have already connected like 25 plus digital systems are exchanging data via our health information mediator. They were one-to-one, but currently they are now pushing and pulling data from this interoperable layer. Thank you, Mr. Moderator. If I do understand well.
Thank you very much, Mr. Romo. Now let me take this opportunity to welcome the third presenter, Benjamin Doto from the fourth. Yes. Sorry.
Emmanuel Johannes.
Emmanuel Johannes, Chairman of the African Federation of Institutes of Internal Auditors. He's going to present on digital transformation for health, auditing, and risks. And before he does that, let me just give you a brief on his biography. Oh, it's very brief. He's just a director, infrastructure and operations. Oh, not the one. Oh, sorry. Emmanuel is the founder and managing director of Kepler Associates and the chair of African Federation of the Institute of Internal Auditors. He has quite a significant experience in risk management, governance, and leadership. He is a regular speaker in professional forums such as this one on governance and on risks across Africa and outside. He is the authorized trainer of our Association of Certified Fraud Examiners of East Africa, and is a member of our advisory council. With that brief introduction, Emmanuel Johannes, you are welcome.
Okay, thank you. Thank you very much, Mr. Chair. And I would like to know how much time do I have to do my presentation?
It's 15 minutes.
Okay, thank you. Okay, so good afternoon, everyone. And I would like to turn off my video and move to my presentation. First of all, my apologies if I have any challenges on the quality of the internet. I would always try to connect, let me know. But I hope I will have smooth 15 minutes to talk about the challenges regarding to how can you audit and the risk associated in those areas. So I'm a bit out of this industry in a sense that I'm coming from another angle, looking at what are the things that we should pay attention for the purpose of accountability of the systems or solutions we develop in the healthcare. So I will talk a little bit about what we do as auditors, and also the risk associated with the digital health solutions. And then I will conclude my presentation. So first of all, I would like to define what is auditing, specifically internal auditing, which is more concerned with the review of the systems and processes. So this is an independent and objective assurance and consulting activity that is designed to add value. But the main objective is to help you achieve your objectives by bringing a systematic, disciplined approach to evaluate and improve. So the key words here is evaluate and improve the effectiveness of risk management, control, and governance processes. So I know this forum has been focusing on innovations, solutions, how you can use artificial intelligence and other emerging technologies in providing the digital healthy solutions. But then at the same time, as auditors, we are more concerned with providing you with an independent assurance that whatever solutions that you're providing, whatever things that you have designed, then they are happening in an orderly manner, following all the key principles of governance and accountability. Of course, we'll talk a little bit later about the ethical responsibility of the solutions that you're providing in terms of the security and other matters. So basically, we are on third line according to our theories of internal auditing. So with the third line, our role is to give you independent and objective assurance and advice on all matters relating to achievement of objectives. When it comes specifically to designing of systems, the role of auditors is to independently review and contribute, give input relating to internal controls in those systems. Yeah, so in this case, internal controls regarding security of data, information, the accuracy of the information that the systems may be producing. So those are the roles that auditors are concerned when it comes to the digital, to the development of systems and solutions. So, and now, if I go and define also risk management, so before we can combine all together, risk has been defined as the effect of uncertainty on objectives. So in this case, you have heard here a presentation, the previous speaker. You develop your strategic plan, you develop your goals and what you want to achieve in the next 5 years. But then there's a lot of uncertainties. The uncertainties could include the funding available, the technical expertise available, developments in technology, so all of those could be some of the uncertainties. So our role as far as risk management is concerned is to help you make informed decision. So, and increase the chance of you achieving your objectives. So how do we help you achieve your objectives? So one of the things that we are striving to advise you is, do you know what are the key uncertainties that could have impact in the strategy that you want to achieve? So even if you are talking about, we are going to develop this solution for non-communicable diseases by 2027, it will take these resources. So the question is, and what we come in, we give you some sort of thinking to balance your perspective and say, you may be able to achieve this within 1 year, but it may also delay and being achieved in 3 or 5 years. So have you considered all sides of this? And what could be the measures that you could take, for example, to make sure that everything is happened within the period that has been offered, or you are even doing it at a shorter time? So basically, when it comes to risk management, it's not something difficult. It's about making informed decisions. So considering the options available, so that's a focus as far as risky management is concerned. And when we are talking about risks, I have identified some very few risks from the digital health, some of the challenges that I consider are important for these discussions. For example, there has been a lot of growth of unstructured data. You are developing systems or solutions that are collecting a lot of unstructured data. So the key question is, where do we store those data? How do we protect those data? Yeah, so, and I will come to that shortly. But also with technologies, you are talking, for example, the use of artificial intelligence, let's say, to predict certain aspects which may have an impact on the solution that is going to be proposed to a patient or to anyone. So the question is, there are some of the challenges regarding the ethics of the decisions which are being made by machines, by robots, and so on. So have you considered those in the design? Yeah. And if not, what can be done? And if it happens in some cases where we may have some false solutions, then how would we deal with it? Yeah. So the concern that we have from the audit perspective is more or less to make sure you have considered all parameters. If we talk about the infrastructures, the platforms that you are using, the IT platforms, are they standardized platforms? Yeah. Are they compatible with each other? Can they talk to each other? You know, the scalability of those platforms, you know, how is it working? Yeah. And the reason we are concerned about this is because we don't want you to design something new for everything. So would you be able to save resources by designing something that can scale up, you know, to any size at minimum cost? Yeah. But not only that, we are also concerned with the cyber threats. I think by 2016, the healthcare was the #1 industry that has been attacked more by cyber attacks. Yeah. So which means it's a big industry and there's a lot of interest, but it has been attacked. So not only that, even the systems and I mean the machines that are produced now, they use technology, they use storage devices, and they have they have chips in them. So they're intelligent machines, you know. So how have we factored the fact that those intelligent machines can be hacked by cyber attacks, and they can be amended or malfunction as a result of those? So those are some of the things as far as the risks is concerned. And when we come to audit, these are the key things I consider as of now that we should be concerned of. So, and how do we deal with them? I would skip this discussion of risk. I would like to propose a solution by saying when we are dealing with the digital health, or we are designing digital health solutions, we should be concerned with the governance of the technology. So, and with the governance of the technology, we should look at three things. First of all, are we realizing the benefit which was intended when we started our design? So this requires us, before you design any solution, to have a clear business case which indicates how the performance would be measured. What would you consider as a success? So that we can come back and look at the investment that you have made and what are the benefits that are going to be delivered. And we would be able to say, this is what was expected. We have met our target and we are happy about this investment. You know, so as auditors, we are concerned with the benefits that are going to be realized by the systems. But one of the things that we have seen consistently over time is the fact that most of the solutions are being developed without considering how would you measure the success. So, and in some cases, they are abandoned in between, you know, before they have realized the benefit that was expected. But we are also concerned about optimization of resources. How best, sorry, I've repeated the same word twice. So how best can you use the existing resources and add future resources, you know, so that you can optimize the best of all of all resources that you have. So that is risky, that is resource optimization. So with resource optimization, we are more concerned with how best can you use the existing infrastructure to scale up and develop new solutions with the minimum additions where necessary. But also we are concerned on how you can phase out what is no longer needed, which is considered as a bottleneck. Okay, I've spoken already about risk optimizations, which is more or less like looking at what are the exposures that you may have, where are things could go wrong, where could be the opportunities that you can use to move forward. Okay, so I have explained about this already, so I would skip. So when we talk about resource optimization, as I mentioned, it's about the infrastructure, the IT infrastructure, the people that you have, data and information, yeah, but also the availability of resources to see your strategic plan is being implemented successfully. And so when we consider the IT information and technology governance, which I feel it's critical when you are designing the digital healthy solutions, you need to consider several parameters, and these have been recorded in the framework for the IT governance, which has been developed by the Information and System and Technology and Control Association, which has 5 domains. 1 is direct and align. 2, plan and design. 3, build and implement. 4, deliver and support. 5, monitor and optimize. So if you look at these parameters, for simplicity, direct and align is more on the strategic, on the governance level or leadership level. This is where the role of those who are providing oversight, the board. So the board should direct and align any future development of technological solutions. But then as management, you are more involved with the plan and design. Do you have a strategic plan? What do you need to achieve? What are the technological considerations? Have you considered all other matters? If you are going to build anything, consider all the things that you would need as far as building the technology infrastructures are concerned, or building technological solutions. How are you going to implement? But more importantly, if you have outsourced some of the things, let's say some of your data are being stored in the cloud somewhere, what about the support that you may receive from third parties? Because with the digital technology and transformation, there's a lot of third-party solutions available. But do you have mechanism to manage the third party and the risk associated with the third parties? Do you have the service level agreement? Do you have a system to recover the data and to offer the continuity when challenges may arise? And I think this is one of the areas that has been tested more than any other area during the COVID-19 situations, because some of the third parties went out of business, which automatically they are affecting some of the solutions that organizations have been running. But as auditor, we are actually also on the last component, which is to monitor and optimize. So with monitor and optimize, we are concerned with the auditing, we are concerned with the performance, KPIs of those systems and solutions that have been proposed, of the third-party agreements that you have. Okay, so as I'm going to wind up my presentation, I've mentioned about the cybersecurity was one of the major issues as far as the digital health industry, the healthcare industry is concerned. So we are collecting information, enough information from different people, but we want to make sure those informations are being stored, the confidentiality is taken into account, but they remain what they are, which is the integrity of that data. But also we want to make sure that everything is available when needed. If it's a system, it should be available when needed. If I log in today, I want to connect because I want to describe or to prescribe something to the patient, then the system should be available to interact with me. So, and we can measure this. If you try, let's say for one day, how many times did we have the system outage? So those are some of the things we are concerned from the audit and risk perspective, but also there's a general cybersecurity framework the NIST framework for cybersecurity, which has been developed by the National Institute of Science and Technology in US, which has been globally adopted by many organizations. So apart from everything that I've said, we want to know how can you identify the cyber threats. Remember, we have said cyber threats have been one of the key risks as far as this industry is concerned. So do you have a framework in place? Do you have a mechanism? And have you considered how would you identify cyber threats? How would you protect those solutions against that threat? And if it happens, how would you detect them? If your system is outage today, if there's a ransomware today, how would you respond and how would you recover? So those are some of the challenges that I thought I could share with you in these 15 minutes. And I think the biggest takeaway is when we are designing our solutions, we should have a framework that is guiding us, which is considering all the aspects that are necessary. For example, the support from the third parties, how are we going to manage them? The security of the data, how are we going to manage them? You know, and if you are living in an environment where there's a high level of threats, which means you should invest more in solutions that will provide security. So your design would be affected by the level of risks identified. So not all systems developed will have the same level of security and controls. So the security and controls would be based or classified in terms of, when it comes to availability of information, again, the availability, the resources you use to make sure that the systems is available and you recover as required would also depend on how sensitive is the system and what is the tolerable level of downtime of that system. So, ladies and gentlemen, I would like to conclude my presentation here. I hope you've been able to hear from that end clearly. And I would like to finish with a quote from Warren Buffett, which says, "It's only when the tide goes out that you discover who has been swimming naked." So thank you very much. Over to you, Mr. Chairman. Thank you.
Thank you, Mr. Emmanuel, for quite a nice enlightening presentation. And if you can bear with us, I would wish to welcome the next presenter so that we have two presentations before we invite questions and answers. Are we together? Thank you. So the next presenter is Mr. Eric Kitali from PO Eric Kitali is the Director of ICT in the President Office, Regional Administration and Local Government since 2015. He has been the key player in designing, development, installation, commissioning, and supporting countrywide ICT enterprise system across the country. And among the systems he has been involved is the Muhas, which is used by all 184 local government authorities. Has been involved also in the good homies. That is used by almost 1,090 facilities. Has been involved in the financial system, the FAST system, which is operating in 36,000 facilities, involved in plan rep and other quite important systems. With that introduction, let me welcome Mr. Eric Kitali to present to us about primary healthcare digital transformation in Tanzania.
Hello.
Hello.
Hello, do you hear me?
Sure, we are hearing you quite clearly.
Yes, my name is Mark. On behalf of Mr. Eric Kitali, I think we'll be presenting the primary health care digital transformation.
Mr. Eric is not available, so we'll be taking the two of us. It will be Mr. Mark, who is the systems analyst from PureRaj, and Madam Jacinta also will be taking a part of the presentation. So for me, I'll go through by just trying to give you a highlight of how PureRaj is administrative areas, administrative hierarchy, and the. So if I go on, how do you understand? Hello. Hello, do you still hear me?
Yes, yes, we can hear.
So yes, I'll start with my first presentation. As I've said, will be
Tanda.
Yes.
Umeshare presentation ambayo sio ile ya mwisho.
Okay. I'm sorry, I've shared the wrong presentation. One minute, please. Just give me a minute.
Can I take the questions while they are organizing, because I'm actually on a move. I'm actually in Arusha, transitioning between one place to another. So would you mind if I spend 3 minutes taking my questions so that I can move forward?
Okay, just.
We welcome questions on presentations from Mr. Emmanuel with regards to auditing IT solutions. From the audience? What about from the virtual participants? Do we have any? Felix?
No.
No. Oh. So I'm sorry, Mr. Emmanuel, I've been keeping you. Well, actually, there weren't questions made or comments. It seems like everything was very clear with regards to auditing IT solutions. But as usual, there are those who come up a bit late with questions. So if you persevere, there's one question that is coming. Please, if you may come here so that he gets the question straight.
Hello.
Thank you, President. My name is Dr.
I think we are ready.
Okay, Mark, just 1 minute. I'm answering the one question and then you can proceed. If you can hold on for 1 minute, Mark. Okay, just hold on for 1 minute, please. Yes. Yes, go ahead, madam.
Okay, thank you. Thank you. Thank you.
While you're presenting, there are some factors that you mentioned, which were cause of risk, such as unstructured data, the use of artificial intelligence. So I'm just wondering, how is the participation of auditors during the preparation of these packages or these applications? Because it seems that we said we cannot measure if you do not know what was the objective, then it's difficult to measure. Some of these are happened in the midway because you cannot measure the findings. So do you think, are you actually involved in the making of these applications? Or is there a gap in that maybe that should be fixed so that we don't face this kind of difficulties? Because at the end of the day, it's very expensive to create something that you cannot measure, you cannot use in the future, and then you end up rejecting it. So how are the auditors involved in the whole process?
Okay, Mr. The moderator, can you repeat the question for me? There was a lot of echoes, so if you can rephrase, moderator, I can hear you clear. So if you can repeat that question to me, please. Yes.
I think the question is, in your profession, to what extent have you been involved in auditing our systems? And I think that the person who asked will be quite interested to hear about health systems, IT solutions that we are working with. Is that what I...
Actually, it's not the auditing part, because the audit is something that is already there. What I want to know is, are you involved in the creation? Because now during the creation, that's when you can see whether there are gaps that have to be made because you mentioned one of the things that happens in this some of these systems is that not be able to audit them because they are not measurable. So maybe during the creation of these systems, what are the involvement of the auditors in that?
Yes, thank you. Okay, sorry, the voice, the echoes was distracting a bit. So basically, first of all, as auditors, we are guided by international standards. And the good thing about auditing, the standards we use, they are universal. So in Tanzania, in US, we are using the same standards. In cybersecurity, we have guidelines for artificial intelligence, for everything. So, but what I'm trying to say is auditors should be involved in the design of these systems. They should be involved in the implementation, and they should be involved in the post-implementation testing. So auditors need to be involved in all these phases because they become as advisors to make sure that some of those things that I've mentioned in the presentation, especially the risks identified, they are being incorporated in the design. They are also being involved in the execution to see if the system is actually doing what it was supposed to do. And this has been done basically even in the normal other industries. I've worked in financial services industry. For example, all banks, when they have implemented their systems, they call auditors to do the post-implementation review. So they want someone independent to look at what has been designed and to see if it is working as intended. So I believe it's the same solutions or same things and same thinking that should be followed in the design of the digital healthy systems or solutions. If I have answered your question, Madam.
Yeah, I can see her nodding. Surely you have.
Yes.
Thank you again, Mr. Emmanuel, for your perseverance and being able to be there to respond to questions.
Thank you. And I've shared my presentation on the chat box. So anyone can download the PowerPoint is on the chat box. There are more detailed information you can follow. So thank you very much.
Thank you. Now let me turn back to Mr. Mark, who is representing Eric to proceed with the presentation, and also if he has some experience with auditing of the number of health systems, information, the IT solutions that they have been developing, whether they involved auditors or they didn't, and to what extent they involved. Please, the floor is yours.
Oh, thank you once again. Good afternoon once again. As I've said, my name is Mark from PRAJ, President's Office, Regional Administration and Local Government. On behalf of Mr. Eric Kitali, who is the Director of ICT, we are the 12 of us. me, who's Mark, who's the systems analyst at PureRaj, and Madam Jacinta, who is also going to take part in this presentation. I just do the part of the introductory of this presentation. We'll be presenting regarding the primary healthcare digital transformation. And by beginning, we thought it would be better for you guys to at least to understand, to have the overview and the understanding of how the administrative hierarchy of PureRaj and the ICT readiness, regarding the infrastructure and the digitalization of the healthy system. So I will start. By the introduction. This is the administrative hierarchy of PureRaj, that we do have 26 regions, 139 districts, 184 LJs, 570 divisions, 3,956 wards, and 12,318 villages, and we do have 5,861 health facilities. Hello? Do you get me?
Slides.
You don't see.
Yeah. Thank you.
Okay, now you see it clearly, right?
Yep.
All right. So this is the administrative hierarchy of PureRaj. And this is the glance. It's the PureRaj one. The wide area network of PureRaj at a glance. That means we are connected to up to 184 local government authorities. Of course, the technology which been used to connect, it depends with the area where the LOGA is located. We do connect them through ADCL, optic fiber cable, broadband radio, and VSAT. Though right now we have a lot of local government authorities which are being connected by using optic fiber cables. And a few of them, they are being connected with the ADCL, the broadband, and the VSAT. So at a glance, this is the PureRaj one. You could see the connection of PureRaj. You see PureRaj with the local government authorities, but both are being connected by the national ICT backbone. And we will talk about GoToMIS a little bit. The GoToMIS has been developed, but during development, we have to make sure we complied with the following strategic alignment, the national strategic alignment. Of course, we had to comply with the ruling party manifesto, the health sector strategic plan, the National Digital Health Strategy 2019 to 2024, WHO guidelines, and other national guidelines, for example, IGA and other institutions. Now, this was the digitalization of the health system development path. GoToMIS in 2012 started as just a revenue collection system, which was called FOPay. That was 2012, and then it was upgraded in GoToMIS version 1 in 2015, where there was some additional of some modules like registration, payments, pharmacy, OPD, and IPD, and the diagnostic, and some special clinics. And we had another version, which was version 2, 2016, with mentioned modules. We did go to GoToMIS version 3 in 2017. And right now in 2019, it's the same GoToMIS, which is currently being used, but with some improvements, because there's a lot of system has been integrated with GoToMIS. Apart from ELMIS and the NHIF, we also have integrated with the GPG, the National Client Registry, DHIS2, and a lot of other systems. But also, GoToMIS have been implemented in 1,090 health facilities. Right now, GoToMIS also can accommodate the CTC module, even CTC and the HTS module, even though it hasn't been used, but it's there to be used. With GoToMIS, we expect that a lot of system could be integrated, to facilitate the continuum of care. For example, system which are being in community systems. We're trying to find a way as a nation to see how we will synergize these efforts, because you could see there's a lot of community system out there. Everyone who is coming, every partner who is coming, he's coming with his own or her own system. So it has been very difficult to monitor those systems. If you could mention it's about 50 systems using different platforms. So I think it's a time right now that we could, if we want to manage them in a good way, and try to make sure that these systems could exchange data with the facility systems like GoToMIS and the Afya Care. I think it's time now we should try to find a good way to harmonize those efforts and make sure that we remove these mushrooms of system from the community, and make sure that we remain with the one single system that could help, that could capture all the information from the community and try to communicate with the systems which are found in the facility. So from there, I think the next slide, it will take care by Madam Jacinta, who is there also to help me in finalizing this presentation. Thank you. Madam Jacinta, you're welcome.
Okay, thank you, Mark. Can you hear me all?
Yes.
Yeah, having heard from Mark that PIORAG has already established the ICT infrastructure as a readiness to come to digital era. And also PIORAG actually is managing the primary healthcare facilities. And we have a total of 5,861 health facilities. And as we have heard from Mark, it's only 1,090 health facilities have been digitalized, which means they are the ones who are currently using the GoToMIS, the Government of Tanzania Health Operation Management Information System, the digital system that is developed by PIORAG in collaboration with the other stakeholders and the Ministry of Health for being used at the primary health facilities. Now, having seen that to date, we have only those few health facilities that are using the system, then we came up to think that we need to have something that will coordinate all stakeholders to be able to implement the system throughout the country to all 5,861 health facilities. We know that the digitalization of health services requires actually a lot of efforts, including infrastructures, capacity building, and so on. So we had different stakeholders who have been supporting here and there, but we realized that we need to have something that will be able to coordinate all stakeholders to come up with strategies that will enable PRAG to be able to digitalize the primary healthcare facilities. So we have developed the primary healthcare digitalization roadmap. And as we are talking now, we already have a draft in place. And we take into consideration when we are developing the roadmap, consideration of the national strategic documents, as well as other international guidelines and directives when we are developing the roadmap. Mark, can you go? Yeah, and what I'm going to take you through is just the summary of the most important content of the roadmap. And the scope of the roadmap has taken care of the community level, and we take care of all dispensaries, health centers, and the district hospitals in Tanzania. This is where PRAG is coordinating the health service delivery at the country, that we have community dispensaries, health centers, and the district hospitals. And the roadmap is proposed to be of 5 years from 2021 to 2016. And it addresses information system technologies and enabling environment for PHC digitalization. It also addresses aspects of deployment throughout the country. And we have taken into consideration infrastructure and other essentials that are necessary for PHC digitalization. Mark? And the general objective of the roadmap is to lay out and communicate the plan on primary healthcare digitalization transformation, and specifically is to coordinate and collaborate with PHC partners by putting a common vision and implementation plan towards PHC digitalization transformation. And it also, the aim is also to align resources and efforts by government and partners who are implementing PHC. The roadmap will also aid to soliciting additional resources to be used in accelerating PHC implementation. No? Yeah, before developing the roadmap, we actually went several steps to come up with the roadmap. We started with a desk review where we went through various strategic national documents. And then we visited a total of 16 primary healthcare facilities in a composition of dispensaries, health centers, and district hospital to see the real situation and come up with requirements for PHC digitalization. Mark? And in brief, the roadmap has been developed, and we came up with 6 broad areas based on the situation analysis that we conducted by visiting health facilities and also by reviewing the strategic documents. And the area 1, we found that we still have some challenges in governance and the policy issues. We already have some guidelines and the policies that are guiding digitalization processes, but we still have some areas that we need policy guidelines to guide on how to go about the digitalization processes. And under each this broad area, for example, the area 1 is governance and policy. We created the priority areas under each broad area. And under each priority, we have activities that after being implemented, they are going to achieve that priority. And these priority areas are the one, when implemented, are going to lead us into achieving the broad area. So we have a broad area and then priorities. And under each priorities, we have activities. So this is just a summary. So you have to understand that under each priority area, we also have activities that are being developed for to lead to the achievement of each priority area, and then to achieve the broad area. So under the governance and the policy, we have 2 priority areas, and as you can see, and the one is to create the enabling environment and enabling governance for the digitalization of PHC. And the other one is to institutionalize capacity building practices to strengthen the use of the PHC digital system and the data. We know that we still have challenges on issues of data use. And we know that with the digital solutions, we are going to have a lot of data, and we need to use those data for decision making. And it's where that we are going to improve our service delivery. So under this, we have these 2 priority areas. So the other broad area is a PHC digital system. For this case, we already have a digital system in place, which is Muhas. But as we all know that once you have a system, it's not that this is the end. The system always keeps growing depending on the stakeholders' requirements, technologies, and other factors. So we already have system in place, but we need to keep improving the systems. And under this broad area B, which is the PHC digital system, we have this 4 priority areas. The one is to enhance Muhas to incorporate new requirements. We are still having new requirements from stakeholders, as I have said, but also there are technological changes and other factors. So we need to keep on improving the system. And the second priority is to develop a version of Muhas suitable for low resource facilities. As I said, we have dispensaries, health centers, and district hospitals which are under PROD. And we have seen that in some low facilities, and specifically the dispensaries, some of them, they do have just a few population that is saved by that particular dispensaries. Also, the human resource in some of these dispensaries, they are few. You may find that the 2 of them or 1 of them saving the population, and that is specifically dispensary. And we thought that such kind of facility does not require as huge investments as the one that is that can be at the district hospital or at the big health centers. So we need to develop a version of the system that can save those lower facilities. And actually they won't require, for example, like infrastructures, for example, the server for such a facility can be of a certain capacity, cannot be the same as the one at the health center or the district hospitals. So we need to develop a version that can suit for that for such facilities. And the other one is building mechanism for data sharing across facilities. As we know, patients can move from one facility to another, and we have to make sure that we have a mechanism where when one patient moves from one facility to another, the information from where he was given service should be also accessible to the to other facilities where he or she can attend anywhere. And the other priority under this broad area is data visualization for PHC digital system to facilitate the data use. As we know that this is very important, data use for decision making. So these are the 4 priority areas that we thought should be worked on to make sure that we have a system that is comprehensive, be able to improve service delivery. Mark, again. The other area is information system integration. As we know that we already have several systems in the health sector, and sometimes you find that those systems are collecting the same information. So we think that it is important if these systems can share information instead of each system collecting the same information. It will be a burden to health workers. And under this area, the priority one is to integrate primary healthcare digital system with the other digital healthcare systems, and also to integrate the GoTHOMIS with the biomedical devices. And the other priority is to integrate the PHC digital system with the community health digital system. We also have systems that are currently working at the community level, and there are several of them, but initiatives are being made that PROG, in collaboration with the Ministry of Health and other stakeholders, are making initiatives to make sure that we have one community system. And once we have that one community system, then that system can be integrated with GoTHOMIS. So information from the community can be available at all levels, from dispensaries to health centers, then to PROG and the other stakeholders. Okay. And the other area that we saw that it is very important, and it's a challenge that is still existing, is digital and data infrastructure. Yeah, we all know that it is very important that we have a reliable infrastructures to be able to digitalize the healthcare, to digitalize the health services. And under this area, we thought that the priority areas should include equipping primary healthcare facilities with sufficient computing equipment. And the other one is to implement networking infrastructure. We all know that patient information is very sensitive, so they should not be accessed they should not be accessed through normal internet. So we need networking infrastructure for accessing the patient's information. The other one is also to make sure that the facilities have reliable power backup, so that they can access the system all the time. And the other area is to implement last mile connectivity for PHC facilities. And the last one is to provide resilient data storage backup infrastructure for PHC facilities. Okay, so these are the 5 priorities under the area digital data and the infrastructure. And the other area is information system rollout. So once we have all that, what I've mentioned above, we need now to roll out the system. But the priority here is to develop a digital system rollout plan. We need to have a plan that will lead how the system can be rolled out. And then the other priority is now to deploy the PHC digital system based on the rollout plan that should be developed. And this is the last area, and I think this one is the most important one if we want to be succeeded in information system, and this is health workforce capacity. And under this area, we thought that the priority should be building the capacity of the system users at all levels. And the other one is to build the capacity of system developers to adopt standards based on the Tanzania health enterprise architecture and the technologies recommended for a health information system. I know that we had a presentation on Tanzania health enterprise architecture, I think in the morning. So we need to make sure that our developers have the capacity when they are developing systems, they should comply with the standards that are being set by the country. As I said, this is just a summary of the roadmap that we have. We already have draft. So this is just a summary of what is actually in the roadmap. And just having said that, thank you for listening.
Thank you, Mr. Mark and for your nice presentation on transformation of primary healthcare IT strategy. Now it's time to receive some questions from the audience. And I can see one there. Please, if you may come forward. Do we have another person who has a question so I come closer? Please.
Thank you very much for this opportunity, and thank you for the presenters for this presentation. My question is, we know that good innovations are the ones that use existing platforms, and so far the focus is great data system and digitization system from the government. What are your plans to make sure that innovators can easily build solutions on your platform? For example, do you have plans to develop application programming interface that could enable to make it easy for operators to build solutions based on your platform?
Thank you. I don't see any other question. So you can respond to that.
Excuse me.
Hello?
Hello.
Yeah. We can hardly hear the Madam Jacinta.
Yes, I didn't get him well, and if possible, maybe he write the question.
The question is whether you have opportunity for innovators to come in, especially in the morning we had in the strategies that we want to improve or strengthen our youth so that they take part in the transformation of IT in our country. And this one actually is a youth, and he's asking, is there room of
opportunity for them, the innovators, to come up with innovations in your IT solutions that you are developing?
Madam Jacinta, can I respond to that question? And maybe you could add, yes. For us, there is always a room, because GoToMe's is a very flexible platform and a very scalable. But as long as there is an innovation somewhere, we welcome people to work with the government so that we could improve our system and make sure that it solves whatever needed with the community. So there's always a room. And for example, GoToMe is using HL7 standard. So whenever you want for an interoperability, then it's very clear that I can be integrated or exchange data with any system if it's the case of exchanging data with the system, but also if there's a new innovation, then we welcome people to come and they share it with the government, then we could work together with the person sharing. Thank you.
Thank you, Mark. And so do we have questions from you? Reach your side.
I'm not connected to them.
Okay, so I'm gathered here that there are a few questions on the Zoom. If you can respond, then we will read the questions and answers when we come back from lunch break. Let me take this opportunity to you both, Mark and Jacinta, and also send our greetings to Eric. And we are very happy with your presentation and with your participation. And I think you can hear the clap from the audience. Please. Now I'm guided by the organizers. Whether lunch is ready. I can hear a yes. So, we are guided to take our lunch for 30 minutes, if possible. And so we should be here by 2:30. That will help us because we already have almost 1 hour. So, bon appetit. Let's be here
Merci.
at 2:30.
Good afternoon, everybody. Sorry for the slight delay. I had some connectivity hiccups. Dr. Felix or Menikiti, am I already on? Good afternoon, everybody. This is Heiko Hornung from D3. Can someone please give me feedback if you can hear me?
Yes, we can hear you.
Excellent. So, yes, I'm now getting also the feedback from Dr. Felix. Yeah, first of all, thanks for the invitation and the opportunity to present some of our experiences. It's really great to see this event today because it really brings together government, university, academia, and practitioners. And I think this is exactly the right ecosystem to start conversations around digital health, challenges, experiences, potential for innovation, progress on ongoing activities, and so on. So my presentation is the first one in the implementation and innovations session. And the topic is to relate about some experiences that we have in the Zanzibar Community Health Program. So my name is Heiko Hornung. I'm working with D3 International. I'm based in Zanzibar, but also frequently in Dar es Salaam. My usual position at D3 is Director of Digital Solutions, where I'm responsible for overseeing the design and development of all our digital tools. At the moment, I'm also the acting Zanzibar Director. Next slide, please. Or I can also share my screen if that's easier. Maybe let's try that and then. Okay, it seems you can see my screen in presentation mode. So before I start talking about experiences and what are the challenges we experience, what are the learnings we had, what are potentials for innovation, I want to start with a quick overview of the program that I'm talking about. So the program's name is Jamini Afya, and it is Zanzibar's Community Health Program, which means it is not a D3 program, it is a program led by the government. And we are very proud to say that it's, to the best of our knowledge, the first ever digitally enabled community health program that has been scaled to national scale, and that is led by a government as part of their formal government health system. So it's a community health program, which means community health volunteers are providing services at household level, focused on health promotion, health education around different health areas. And the program is digitally enabled, which means CHVs have a smartphone app that helps them for work planning and for maintaining good quality of operating procedures and protocols. And the program is digitally enabled to be able to collect high quality data for decision and policy making. The program also implements Zanzibar's community health strategy, which also has been updated in the wake of this program, to provide one unified platform for community health in Zanzibar, which all partners and all ministry programs and units are encouraged to use. The initial goal of that program is to improve maternal and child health and well-being. These were the initial program goals, and this already speaks to the development process. The development process is incremental and iterative, and maternal and child health were the first priority areas identified. But obviously there's a long-term goal. As I said, this is Zanzibar's community health program. So the long-term goal is to focus on community health indicators to improve the well-being of the entire Zanzibar population and increase access to health services at the community level. And by that increased access, also increase the demand for health services at the facility level. I will not go into all of the details of this slide because we have limited time. I just show this slide to give you all an impression about the history of that program. So the program actually started over 10 years ago with smaller pilots that have then been successively scaled. And at some point, 3 to 4 years ago, we got together on one table with other community health partners and with the ministry in Zanzibar to join forces and to discuss how all related partners can work together to build one community health program. And then in 2018, we started working even more closely with the Ministry of Health in Zanzibar to then start designing this one community health program, supported by the update of the community health strategy, which we also work together with implementing partners and the government. And then finally, in 2019, the same year as the digital health strategy in Zanzibar also launched, we launched a program first in one district and then successively scaling up into all 11 districts of Zanzibar. In the process, the digital health strategy was launched, as I mentioned, and about a year and a half ago, we started DHIS2 integration, which we finalized more or less a year ago. So since 2021, the community health data is also part of Zanzibar's community health information system. The next phase of this program will be on focusing on government ownership and government management. So this just to give you an idea of the history of that program. This is not something that just started a few years ago. It is something that already has quite some history, including the digital components of the program. Another slide where I also don't want to go into all details, but just to stress some important points. This symposium here is about digital health, and my personal background is also in computer science and digital design. But what I want to stress here, that the digital components of a program are only one part, and any program has many other important pillars, and so does Jamini Afya. So if you look at this slide, we have two pillars that speak to digital systems, which is the digital platform, which CHVs and supervisors use, and the integration with the DHIS2 system. All the other pillars are non-digital pillars, and they are very important and essential for the success of the program. So the program really takes a comprehensive approach, starts from defining the CHV package, talks about CHV recruitment, CHV qualifications and training. Then, of course, for a national scale program with comprehensive services, CHV workload is the topic, and then many other topics that are listed on this slide, but that I don't want to go into for the interest of time. This slide here shows the general structure of the program, and here we can also talk a little bit about the digital components of this community health program. At the lowest level of this structure, we have the communities that are served by CHVs. We did work planning, workload planning, and ran some simulations while we were designing the program. And according to these estimates, we determined that also considering the status of a community health worker as a volunteer, a population size or a catchment area size of 700 to 1,000 per one CHV would be a workload that can be managed by a community health volunteer. So this is the lowest level. CHVs, as I said, conduct household level visits, but also group visits in the communities about certain topics. And 5 to 15 CHVs work together in one group that is mentored by one supervisor that sits at facility level. That facility level supervisor is usually an environmental health officer. In facilities where this position is not filled, the supervisor can also be a nurse. And then an additional support structure at this lower level are the peer mentors. So within each supervisory group, we have 1 to 2 CHV peer mentors who can provide additional support to the CHVs. And then if we go up one additional level, we have the council health management teams and the central ministry units for coordination and oversight. At all 3 levels, we use digital tools. At the CHV level, we use a smartphone app for work planning, for task planning, and for support during visit conduction in order to assure quality and adherence to protocols. CHVs also can see some of their own performance data, like their monthly targets, as they are paid incentives based on the targets they achieve. And then on that middle layer, at the supervisor level, we have an app that shows, at the moment, basic program monitoring data, so that CHV supervisors can follow up with CHVs who, according to the data, are not performing well and can try to find out what might be the reasons of that underperformance. And then at the top level of the program, we have both DHIS2 dashboards and custom dashboards at the moment, because when we started rolling out the program, the DHIS2 integration was not ready yet. So we wanted to provide some data tools to council health management teams and health promotion unit colleagues at the central level to provide them with information for decision making. That's why we also have some custom dashboards, but the vision is to migrate these custom dashboards over to DHIS2. The progress to date, Jamini Afya as a program in its own right, succeeding previous programs from various implementing partners, started 2018 already with the collaboration of the ministry partners and the district level partners, already starting with sustainability in mind and already starting from the outset with discussions around capacity building and government ownership. Since January this year, community health data has been integrated into DHIS2. Since August, the program has reached full scale and is now active in all districts of Zanzibar, which means we have currently more than 2,200 CHVs actively serving communities, supported by more than 200 supervisors. And that means that with very few exceptions of, for example, dropouts or retired CHVs, each household in Zanzibar has access to a CHV who conducts visits to these households. That's the current status, and going forward, we will of course also continue to monitor and evaluate the program, but also, and that's very important for the program, start intensifying discussions around institutionalization of the program and transitioning more ownership to the ministry, which includes financial ownership, programmatic, but also technological ownership. Another view, another perspective on the progress made so far is that we already have more than 80% of the Zanzibar population enrolled into the program. Most districts already have an enrollment level of around 90%. At the moment, we have 1.3 million Zanzibari enrolled in the system. And this shows that there's a very good acceptance and buy-in from the population, which also emphasizes the potential impact of a community health program like this at Zanzibar scale. Among the pregnant clients that we have enrolled into the system, we see that 86% of those clients have health facility deliveries, which is above the health facility delivery rate for Zanzibar, at least according to the latest information we found. These impact figures that I'm showing now, or let's say outcome figures, we need to take them with a grain of salt because we are still scaling up, and it can be that for now we are reaching clients that are easy to reach. So we expect that in the future, these numbers will adjust a bit. Another strong indicator that we have seen is that 95% of the women who are referred by a CHV to a facility really complete these referrals to the health facility, which is a really significant increase as compared to what we have seen earlier in earlier community health programs. And 75% of the community health volunteers meet their performance targets. And we attribute this to a strong digitally enhanced supervision system. I mentioned the facility-based supervisors, that they have a supervision tool, but also the community health management teams, they also have supervisory tools to support the whole program structure. So what the program is still very young. We started in 2018 and we just reached national scale a quarter ago. But what are so far critical success factors that we see? For starters, I think it was very important that we started with sustainability in mind. And not only 2018 when we actually started Jamini Afya, but even before, when D3 and Save the Children and UNICEF, who were the main or are the main community health players in Zanzibar, while they were already working or still working on their own programs. At that time, we were already discussing how a community health program can be really designed, built, and then operated with long-term sustainability and with full government ownership. And this means that from the start, we had a capacity building plan that we implemented since the early days of the program. For example, we have ministry colleagues who are seconded to D3, who are already operating aspects of the program, both programmatically and in terms of technology. We also seconded one of our staff to the ministry for further capacity building. We built the whole platform for integration into government systems, and I think we have seen other presentations this morning that have stressed how important that is. So for example, when we started talking about digital tools, digital platform, we were already thinking about how the government can own this, what this means in terms of requirements like open source, global goods, server hosting, data integration or integration into other systems. And then this already ties into that next point. From the start, we were really thinking very detailedly about how this program can achieve government ownership, both financially, programmatically, and technologically. And this even goes so far that when we first pitched that idea to some of the donors in 2016, 2017, we already really promoted that idea of government ownership and chose donors who bought into a really long-term vision, who accepted that a program like this that needs to transition into government ownership is not a one-year program, it's not a 4-year program, it can be a very long program. And we were first trying to find the right balance to attract donors and not scare them away. And we were planning with proposals around 5 to 7 years, but then one of our donors really told us that we should be really transparent and that from their experience, programs like this can take 10 years or longer until they really reach that point of sustainability where things are really sustained and institutionalized into the ministry systems. Another thing that I find is very important, and I cannot stress it enough, especially here in a digital health symposium or digital health venue, we started with the health systems challenge in mind. So we did not start with a digital solution in mind. We did not start with something, oh, we have this community health system, this digital platform that meets some of the use cases Zanzibar might need, and we want to push that. No, very much to the contrary. When we started that program, we really analyzed what are the health systems challenges, what is the capacity, what are the prospects for government ownership, and what are platforms that match the situation that we found in Zanzibar. And then from the start, including platform assessment, platform choice, we used a participatory human-centered design process, which means that we design and develop all programmatic aspects with all relevant stakeholders, which also includes the community health volunteers and also includes feedback from the community. And then this, and I think this is also a very important point, is that we followed an iterative and incremental process, continuously evaluating and improving the program, and not following a big bang approach, but really iterating over this program. So this brings me to the last slide. What is the potential that we see for innovation, as innovation is also a topic here today? A long-term national scale program opens many possibilities for data-driven approaches. And this was a topic in the morning and will be a topic later. So for example, we can predict client behaviors like facility delivery and deliver tailored interventions like precision public health. We can also do other predictions like, for example, predict CHV behaviors to increase their performance or motivation. And that client-centered approach of Jamini Afia can be replicated at lower level facilities to build a digitally enabled system that connects facility and community and that supports health workers instead of making them data collectors, that makes the client journey seamless between community and facility and along the lifetime of a client. And it also increases the quality of care of that whole system instead of building a digital data collection system at facility level that gets in the way of patient health worker interaction. So there's a huge potential. I think in Zanzibar, many people see this potential, including the government, which we are really happy about. But I also want to stress that to realize this innovation, this really requires government leadership and coordination among all stakeholders. So this concludes the presentation. In the interest of time, I only scratched on the surface of many topics, and maybe we have some questions from the audience to dive deeper into some of those. Thank you for your attention.
Thank you. Thank you. Thank you, Dr. April, for enlightening us on how the solution can help us on addressing challenges in the community, especially in regards to health services. Are there questions for Dr. April? And not from the audience. And we have questions from the virtual side. Yes. Okay, so
if you can assist so that we get responses, we will communicate the responses to the audience after we finish with the next presenter. Thank you, Professor. And this brings us to the next presentation, which is by Engineer Dan Schuster. He is going to present on capacity building in biomedical engineering in low and middle income countries, and he's going to look at past, present, and future. Engineer Dan is the founder and the executive director of Biomedical Training, which is a non-profit US-based organization, which is also active in Tanzania and Haiti. He's a licensed professional electrical engineer with almost 35 years experience in electronic designing and system experiences in video and television. He has expertise in imaging and image processing. He holds 2 imaging-related patents, 2 PC Magazine Editor Choice Awards, and shares credit for 2 Emmy Awards in television engineering advanced. And since 2010, he has facilitated viable biomedical engineering diploma and bachelor in engineering degrees at Arusha Technical College. With that brief, let me welcome Engineer Dan to present us.
Thank you very much. You know, I taught a lot of biomedical engineering classes right after lunch, so I know the challenge I have here. I expect you to be nodding off. I also have to give you the warning that old men love to tell stories, and you'll be lucky if you only get 5 or 2 or 3. But I want to start with this one. I am so pleased to be here that back at a medical school, because in 1975, as a new Bachelor of Science graduate in engineering physics, I started my first job at Oregon Health Sciences University, which is very much like Muhas in terms of having a dental school, nursing school, medical school, and 3 associated hospitals. And I started in a digital data acquisition system for the neurophysiology department. And I never expected, going from engineering, that a few years later, I would publish a paper called Optimal and Adaptive Control and Canine Postural Regulation in the American Journal of Physiology, July 1980, because that was, at the time, one of the largest medical journal distributions in the world. And being an engineer, I didn't think I would be doing that. But I've come back to that full circle, because bioengineering is what I started with, and it's what I'm ending my career with in retirement. And so I have this other story. So basically, my presentation is a visual documentary of what we've achieved at Arusha Technical College. But I do want to say that we just signed a memorandum of understanding with Muhas, and I believe that biomedical engineering belongs in Muhas, just as it started at the medical school I attended, or I worked at. And I think that the logical bonding of engineering to medicine should happen at a medical school. And that is the point I'm going to try to make. Now, what is the context in terms of digital healthcare? Digital data comes from biomedical instrumentation. Data integrity is maintained by your biomedical engineers. So digital data lasts a really long time and is accessible by everybody. And that includes bad digital data from uncalibrated or defective instruments. Now, we had a term in the 60s called garbage in, garbage out. That was a digital term that if you put garbage into a program, it would come out garbage. The one I developed as an analog designer in digitizing data, and in particular, my specialty was signal conditioning and filtering. I heard the term sewage in the soup. Now, sorry to bring that vision to you right after lunch, but that really is what improper data recording does. So, for instance, if instruments are uncalibrated, the data you get will be trusted because data that comes from digital systems is inherently trusted. We see the problem on social media that people believe anything. So the importance to the context for this symposium is that you are dependent on biomedical engineers. They should correct to get data with integrity. So these are just a few, I started writing just some of the subcategories of biomedical engineering. So what is it? So it's actually broader than any of the medical specialties because every medical specialty has several subcategories of biomedical engineering involved. So for instance, I just mentioned some biosensing, imaging modalities. I counted at least 8. Actually, I started counting more than that. At the lowest end, you're talking about ECG, EMG, and electroencephalograph, electrical, very slow electrical changing fields. At the very top end, you have positron emission tomography, you have electron microscopy. So you've got so much. I don't even want to start covering these things, and I'm not going to. I just put this up so that you'll understand the progression in biomedical engineering is unlimited. So this is a really personal story for me. It started in 2007 when I climbed Kilimanjaro. And my daughter, who was getting her master's in public health, focusing on public health disparities, especially in LMIC countries, she volunteered at a hospital in Moshi. And when I came off the mountain, she realized how much medical equipment was broken or unusable. So I felt the calling to do something. And 2007 was the same year that the World Health Organization confirmed Tanzania as a country where 80% of medical devices are broken. I don't necessarily believe that figure because as well as I do, government institutions can't throw anything away. So when they're counting, they're doing these statistics, they're including some instruments that probably should have been thrown away a long time ago. I have to include my Tanzanian family here, my host family. I couldn't have done it without them. They gave me the local understanding of what I had to do in politics, what I had to do socially, and they still, I'm still Babu, and they still give me advice on how to deal with difficult problems that I encounter. 2010, I started by bringing robotics to Arusha Technical College. These were simple robots. They looked more like toys, so they weren't really accepted, but they did allow me to do some introduction in automation and control. The other thing I did was purchase their first solar powered hardware because power is essential to healthcare. You just don't, all your data, everything else, it doesn't matter much if you don't have power. And that became very obvious to me at Arusha Technical College when I lose my projector in the middle of the presentation. So we started with faculty training in lab electronics. And to do that, I had to first replace the old equipment that's pictured at the top there with modern digital test equipment. So digital is everywhere in this presentation. Okay, we have a digital theme here, and I stocked electronic parts for prototyping. And I introduced some practical engineering techniques because there were not a lot of labs in electronics. So we started. I should add that Dr. Richard Masica, who was a principal of Arusha Technical College at the time, was essential as a partner in this. Without administrative support, none of this would have been possible. So he developed the motto, or we did it together, that skills make the difference. We determined where the practical needs were, that the practical lab needs were basic. We identified digital test equipment, electronics. I identified digital test equipment, electronics parts, inventory needs, developed the electronics training for the faculty to build lab competence and confidence, because you know the faculty will not try something and be embarrassed in front of students. They have to feel confident in doing it. So the very first phase of any biomedical program has to be developing faculty confidence and competence. And one of the things we did was digital training for traffic light controller. And then with Dr. Masica, we planned biomedical engineering training. So even in this case, Urbanus Malgeri was the head of department of electrical engineering. You see him center left. He was even involved in doing this. I think this exercise was a digital traffic light controller. The same year that traffic lights came to Arusha. So it turns out that ATC actually got the contract, the government contract, to maintain the traffic lights. So hospital equipment, it takes many skills to repair. You need the mechanical repair skills. Plumbing and refrigeration are essential. Electrical power and lighting are critical. Electric motors are everywhere. Computers and telecom are common in higher end hospitals, and most vital medical devices. And medical staff expects the biomedical technician to do it all. So why did we focus on electronic engineering? So our program was diploma, first diploma, then Bachelor of Engineering in electrical and biomedical engineering. Why electronic? Well, biomedical designers were largely electrical engineers up until the 1970s. Even when I designed cardiac pacemakers for Biotronic, which was the largest German-based manufacturer of implantable cardiac pacemakers in Europe, our entire staff was electrical engineers. There were no biomedical engineers at that time. And that was 1986. So medical devices are often digital, both hardware and software. Biosensing requires analog electronics and a lot of signal conditioning. Imaging modalities are both digital and analog, and control systems are digital and analog. Now this one, so the modern scalpel is electrocautery ESU. So I put this one in because my way to actually experience what it was to be a clinical engineer was to volunteer as a clinical engineer at a trauma hospital in Port-au-Prince, Haiti. I had a neurosurgeon come up to me and he asked me, can you fix the plumbing? And oh, by the way, my electrosurgical knife isn't cutting smoothly. Okay, so before you could fix the plumbing, anybody with technical skills could fix the plumbing. What does it take to understand what he was talking about with electrosurgical knife not cutting smoothly? Well, we actually introduced that concept at the diploma level. The concept of mix, the cut coag mix, so that the students all understood the waveforms. But understanding, the tissue interaction of electrosurgical units and just knowing the difference between manufacturers such as Valley Lab or ConMed, which might have different mixes. So the first thing I suspected in that case was this visiting neurosurgeon was used a Valley Lab setting a mixed one, and the mix for content might be slightly different, creating a little more drag. But I really didn't have enough information. What I needed was clinical engineering knowledge. That is what could come from a program here at Muhas, because you have people, you have the ability to really train biomedical engineers at a higher level, even to masters in engineering. So, of course, we have data-connected hospital systems. We have telemedicine and computer informatics, and we certainly touched on that in this. So our first biomedical engineering training was in 2012. We introduced the faculty to, in this case, a CT scanner and X-rays. I brought with me some devices allowing automated blood pressure measurement, Doppler fetal heart rate monitor, ECG cardiac monitor, and the faculty members all built ECG simulators, electrical simulators. Now you'll see right next to me, that's Dr. Musambu was head of engineering for the Ministry of Health at the time. He was our guest speaker and awarded the completion certificates. But one of the things he focused on, which stuck with me, was the need to understand calibration. He said, all the medical devices in Tanzania have to go back to Europe for calibration. Why no field calibration? You need, at a higher level, you need engineers who can understand how to calibrate medical devices. And we have now conducted seminars, and did last year, where we provided oxygen concentrator analyzers, which could determine whether or not oxygen concentrators were putting out what % of pure oxygen they're putting out. Now that was critical. It's critical in these times when oxygen has been a shortage. But it's something that is a higher level. It's not something that you expect at the formal levels to understand. So a lot of this is a whole hierarchy, going from those basic equipment technicians who just get something working to those who can understand calibration and clinical needs. So 2012 was a busy year. We incorporated our small nonprofit. We did a needs assessment for NACDA. DIT did the same. We both got NACDA approval for BME programs, slightly different. But one difference for us is that we had Duke University train our coordinator in a summer health institute. So we started our partnering right away. In subsequent years, Duke and the Engineering World Health trained 6 more ATC faculty, and this was a minimum commitment of 2 months, and then at least a month in a hospital actually repairing equipment. From that, we eventually got partnerships with Clemson and Cornell universities. So we had Duke, Clemson, and Cornell, which are 3 of the top world universities in biomedical. Now, when I first came and talked this over with Dr. Masika, he said, there's no way we're going to get universities like that to Arusha. Well, fortunately for Arusha, everybody wants to go on safari. A lot of people want to climb Kilimanjaro. So it's actually much easier to get people to go to Arusha than Dar es Salaam. So these were our first 13 students. And the Davis Vice President, Dr. Hobi Tam of Clemson is there. He taught anatomy and physiology every year for a week, very intense session. I can say that every single one of these 13 students is highly successful. I will tell you, one of them has his own company, has 15 employees and hired a number of his colleagues from ATC, has 2 floors and makes more money than I ever did. So I would call that success in just 7 years. Here's an example. Every single student had to learn not just how to solder, but how to solder correctly. And that's a skill that actually takes some knowledge. And how to rework circuit boards. because that's the kind of thing that they needed to do. Now, we were short on medical expertise. We would have loved to have the faculty for Muhas, you know, but because we didn't, Obi did the introduction to anatomy and physiology, and then for pathophysiology, each one of the students took an area, a human subsystem, and became an expert in it. And they each gave their own PowerPoint presentation. And that was extremely effective. Now, my daughter, who was a physiatrist, she actually looked at their presentations at the time. She said, these are the quality of a bachelor of nursing student. So they really, you know, we had some really incredible students, but they were able to teach each other pathophysiology, just elementary. The important, most vital thing was frequent hospital visits. So, and this is the Lutheran Medical Center, which is very close to campus. So they're getting instruction from the biomedical technician there, who's actually very good and on X-rays and X-ray systems. This experience actually helped get us a building. This, former President Kikwete and Mkapa both saw our presentation by one of our graduating students. She had built from scratch a microprocessor syringe infusion pump with occlusion detection and bolus delivery. The same thing that many of you may have seen in the hospital, and they did it from scratch. We also got publicity in the Citizen. This was, so at one point, ATC has 6 high-level 12-lead ECG diagnostic machines, which was more than any hospital in the region. Thanks to, again, back to Oregon Health Sciences University. They updated their cath lab, and I got in there and I got 8 high-end machines. 6 of which went to Tanzania and 2 to Haiti. So our 4 cornerstones of success. The faculty multi-month training in IPT, skills-based electronics training, which meant everybody did everything. There was none of the sharing or having the faculty demonstrate. Every project each student had to do. Now that took a lot of support. And it was only possible because we limited the student enrollments at the time. And then we had the industrial practical training with weekly hospital visits and extended summer internship. And that's where they really learned. It's actually hands-on in the hospitals. And then this project-based hardware software integrated learning through microprocessor medical device. The first year, they all had to do the syringe infusion pump. After that, it was up to them. But they had to use a microprocessor, they had to do both hardware and software, because that is the heart of every medical device these days. And then as a result of our success, we were invited to the Association for Advancement of Medical Instrumentation 2015 Summit in Toronto. And these were the visionaries from every continent, except Antarctica, and including the head of biomedical engineering for the World Health Organization, UNESCO, different, you know, all these different organizations. We came together to understand what was necessary for biomedical education in LMIC countries. And we learned and borrowed from each other's experiences. So what was next? At that point, we were looking at a Bachelor of Engineering to be a major. We needed the profession to be self-sustaining, so you have to have degrees all the way to the top, all the way to PhD eventually. We need capacity building at all levels, the PhD. The medical physics is constantly changing, so it really requires a high-level understanding. Imaging modalities are inherently complex, image processing is inherently complex. Health technology management is an emerging field that's really important. And then clinical applications means clinical engineering, understanding how the equipment is used. We even went to digital image processing and FPGA design, which is cutting edge even for American universities at that level. I really actually pushed them beyond what I would expect at a good quality American university. And then we also covered telemedicine and medical informatics. So here's a slide just showing, some in the lower right-hand corner, they're working with these FPGA simulators. We had a visiting PhD from Nelson Mandela Institute. When he saw what we had, he said, well, we're just getting that at PhD level. So having the equipment really made a difference, but having the faculty that knew how to use it was critical. And we had faculty that had done FPGAs that knew how to do that. You have to have the faculty first, then you get the resources. So in 2016, we got the new biomedical lab, but in a few months, we're dedicating an entire floor to biomedical engineering at Arusha Technical College. And I was invited, the principal came down and invited me to dedicate the floor. So that it was probably sometime in March or April. And then here are our first graduates. Several of them already are attending a graduate fellowship. But once we had the Bachelor of Engineering degree, Beta moved on to doing professional seminars. So we did the medical device calibration seminar, as I said, addressing that critical need for data integrity that you need in healthcare, digital healthcare. Our future directions, our last slide. Bachelor of Engineering in Biomedical Telemedicine and AI Informatics. Bachelor of Engineering in Clinical and Biomedical Engineering. Master of Engineering in Clinical and Biomedical Engineering. So we now have a beta memorandum of understanding with Muhas and DIT. Clinical engineering is got to be Muhas based. Now I am trying to convince the administrations to work together to possibly have a collaborative program between DIT and Muhas for some of the technical needs. DIT would provide some of the technical needs. That's a future direction. We don't know where it stands at this point. We will definitely do professional B&E biomedical seminars, workshops, and hope to use Muhas as one of the locations for that. And then we're continuing with international collaborations. So trying to meet the oxygen needs of East Africa. We're actually collaborating with Malawi. We're collaborating with training programs in Zambia, Kenya. So we're trying to establish biomedical engineering as a profession that has some guidelines between neighboring countries. And then the last thing I'll leave you with the slide of who we are. We only achieved this through collaborations with a great number of partners. We're a tiny little nonprofit, and I funded most of it out of my own pocket, along with my wife. But I've been able to use all these different collaborations. So with that, I thank you for your attention.
For quite exciting, nice presentation. And one good thing about people with field experience is that it's very difficult to stop them when they start talking. But one bad thing is that they end up leaving no time for question and answers. So if there are questions, we will take them and address them towards the end, because we are getting pressure from other presenters who are on the line waiting to present. If there are people with questions from the audience, if you raise up your hand, somebody will come and pick the questions from you. Please raise up your hand. You have a question for Engineer Dan. Okay, so again, this was a very interesting presentation, but most of the things were very clear. Do we have questions from the digital side? Okay. So that brings me to the next presentation, which is by David Karunda, who is going to present on the role of universities in promoting innovations in the digital age. David Karunda is a technology specialist with work experience in public, private, international affairs, and development sectors. He believes in responsible use of inclusive modern technologies, having a huge impact on professional practices at individual, organizational, national, and global levels. And his most recent role was working with the data use capacity building program as an officer for data use partnership at PATH in Tanzania, where he was responsible for capacity development of data use in the country healthcare system. Prior to working with PATH, he worked with the Commonwealth in London as IT Service Program Officer in the first cohort of Commonwealth Young Professional Program. He has also worked briefly in banking with NBC Bank and in digital health e-learning with Boresha Afya. With that brief bio sketch of David Karunda, let me welcome him to present to us on the role of universities in promoting innovations in the digital age. You're welcome.
Thank you so much, moderator. Good afternoon, everyone. I hope you can see the screen well.
Yes. Yes.
Okay, thank you. So I'm David Karunda, currently at University of Sussex, and I'm more of a sustainable development scholar looking at sustainability, but again, science and technology from policy studies lenses, as well as how innovation can improvise industrial development and green economic growth. And I have been asked to provide a presentation on the role of universities in promoting innovation in the current digital era. And we're going to have a look at the nexus of innovation in the society that is empowered and can also empower technological changes. But again, what are the capabilities that institutions need to have? So in this particular case, it's about academic institutions. But again, what's the specific role that universities play? How and where do they do that? And the last bit is more food for thought, opportunities for impact so that innovations are sustainable. So just a little bit of, to show the journey. So we've had research and development with strict regulations and competitions from early 1960s, where we saw nations that invested well in research and development grab, the front seat in innovations. But from 1990s, we've got national systems of innovations that now we've had policies around how, as countries, they can progress that. And at the moment, we are more of in an emerging state of transformative change. And we are looking at how institutions, entrepreneurs, policymakers can all come together and work to build a better society, leveraging technological changes. And as previous speakers might have hinted, innovation really is more of a nexus of the society and technology. So we tend to focus more on one side, but I think it's important to have a visibility of both. So when we speak of the societal changes, we look at things like what are the regulations and policies on promoting innovation. But again, how do we address privacy, digital footprint, because most of us nowadays are connected to the internet. But again, what about dual use? There's this fear in some of technologies that how can we trust innovation that leverages or collects data that is going to do good for us. But there's an issue of democracy. How can the society hold accountable innovators when things go wrong? How are they involved from the beginning? And there's an issue of inclusion as well. In the current era, we tend to focus also on marginalized and vulnerable groups. On the technology side, I'll just briefly show current emerging ones. We have Internet of Behaviors, which is a collection of Internet of Things, data analytics to provide insights and more of leveraging behavioral science and psychology to understand better the trends and rational thinking of users of innovations. We have edge computing. How close can we maximize the efficiency when using especially digital technologies? But again, we have blockchain, which is quite a technology that has a potential in the future. And currently, I believe we have various modes of augmentation, virtual reality, and sorts of kind. We also have innovation in terms of automation. So this is different from robotics, but rather seeing how can technology be used to improve production where humans used to do. Bio and nanotechnology, next generation genomics, how is it going to happen? We've seen how this has improved as well in the manufacturing of COVID-19 vaccines within a year. But we have a cluster of artificial intelligence and all the subsets, machine learning, deep learning, and neural networks. But last but not least, reflecting on what our previous presenter had said on security, is to remember that the concept of dual use is that every technology has got good and bad uses. So it's two teams, proponents and opponents. How well do we secure and embed security practices in all that we do? And the last bit is more of sustainability. How do we ensure that as we try to transform our societies, we also focus on the future, long-term impacts, and the future generations. And the next bit is more on now institutional capabilities, where I'll briefly touch on the value chain of innovation from patenting, publishing, producing, and market development. As you can see that the first thing that institutions need to have, in this case universities, is more of business bureaucracy, the evolution of management and leadership to focus more on attaining business value. But also there's an issue of directionality, focus, purpose, and the impact that universities need to create or want to create in the society. It's also important to focus on academic entrepreneurship. How can the knowledge that comes from research and teaching and training be monetized? And with research and development and collaboration with industries, how can all that be commercialized to retain good economic growth? We also have good governance, which will impact stability and attract collaboration and funding. People who are interested in funding research and innovations would always want institutions that have good policies to protect and promote innovations and collaboration. There's an issue of funding as well. Is there funding for fundamental research, especially for academic institutions? Or is the majority of it more of applied research that is specific to donations and grants? And another bit is on knowledge capital. How competent is the workforce? How is the quality in terms of talent attraction, recruitment? How do you develop people more into academic entrepreneurship? How do you retain them or release them into the industry? And as we innovate, what is the public value that institutions hold in the society? And the last bit is more on diversity, equality, and inclusion. This is a current issue, and studies show that with more inclusion, innovation space grows up very fast, and it leads to structural changes, which again attracts more inclusion from people from various backgrounds. And the last bit is more of technology. What are the capabilities? What are the infrastructures that are available? And how well can all the workforce of an institution leverage their internal processes as well as the core business and activities leveraging technologies to improve performance and production as well? Now, the core bit is now where and how do universities fit in. I'm just going to show an illustration that shows the potentiality of universities, because they're right here in the middle, where they can interact with the state, they can interact with the communities, as well as monetize their innovations into the market with multinationals, social enterprises, and small and medium enterprises as well. So universities are placed in a better way and position to interact with various actors in the society. And how do they do that? So universities are more of knowledge production and application. So the key things here are more on how is fundamental research reflected in the core business of universities? How much of that research funding focuses on really creating value and with a great degree of directionality to produce better impact, as well as philosophy. This is very key, because as we do research, it's important to have the ability to really critically evaluate and resolve problems by addressing questions that would eventually create value and essentially form knowledge base for better decisions and guide better innovations. And another thing is more of how does the knowledge that's being generated improve social welfare? How do we change this change? How do we shape the changes in societies? And seeing more of what are the implications, as well as the impact that the knowledge that can be monetized into the market will have on societies. Another bit is more of governance. This is very important, how much emphasis is put on governance from onset of innovation products and also byproducts in areas of technology, data, confidentiality, and other aspects as well. And now we focus more also on interconnectedness and value enrichment. As universities, how are the studies done? Is it single disciplines, or is their approach of interdisciplinary? Because eventually the approach in the knowledge cycles within innovation ecosystems, the more diverse we are, the quicker and more enriching the innovations that we have will be in the society. There's an issue of culture of collaboration. One of very key soft skills in the current digital era is more of collaborating and know how do we really embolden it in our knowledge spaces within academic institutions. We also have an element niche at the moment, which is behavior studies. It's a very powerful tool that enables us to understand better how users and the societies are in terms of rational and irrational thinking, making decisions, and choices. So we've seen this even in the internet platforms, Google, Facebook, and all that. They focus more on behavior studies to know how best the technologies and platforms can actually attract more users and ensure that they keep on using it. And the last bit is more on contemporary issues on sustainability. When we speak of sustainability, we mean of current and future generations. And at the moment, there is an issue of carbon footprint and digital footprint and all that. How do we ensure that we do not make Mother Earth even worse as we try to produce knowledge and products into the society? But also in the current world, there's an issue of chain of custody, environmental sustainability and governance standards, and other standards, which I believe Mr. Emmanuel also touched more on this. So it's more on how do we ensure that from knowledge production and application and diffusion, we ensure that these standards are upheld and adhered to. And now from knowledge production and application, universities have the potential of developing or even exploiting new technologies. So various ideas could be packaged and have centers for innovation and entrepreneurship. But within these centers, to have innovation or staging labs where students, academicians, and even industry practitioners could work together to conceptualize and have ideas on how they want to apply the knowledge generated from fundamental research into useful services and products. Exploration workspaces. Universities have this potential of attracting everyone within the community, since they interact with governments, private sector, and communities, to bring together people to ponder on ideas of the future and current issues that might need academic thinking and research into them. But again, it could be a good space for incubators, whether it's startups that eventually mature from staging labs, or whether these are startups now are ready to enter into the market, like spin-offs. We've seen how universities are assessed in terms of how many of their innovations really go into the market. And I think for stability, having centers of innovation and entrepreneurship, it's easier to have good business support and ensure that these investments do not go into waste. But again, as the previous slide showed, it's more of communities. This is bringing together practitioners, students, and members of the society to see how best the centers can be used to address issues that are facing them. And there's an issue of knowledge exchange between the industry and the academia. Having people working together, whether in developing or exploiting, understanding the fundamental basis, as well as how best these products and services can be focusing more on bringing value in the market. But also, how do we address issues around grants and donations and the linkage to industries, which have got more resources for funding research and development. And the last bit is more on business support. If the universities are going to have business bureaucracy, then it's much better in the leadership to also account for the necessary support that all these brilliant minds will need, because you have a gap between academics and industry. So someone who can actually, who can support better innovators throughout their stages. And the last bit is more on empowering markets with skills and products. So innovation can be in terms of skills, the processes, how to do things, but again, it can be products. And how do universities play this role within the markets? So producing graduates, fit for new markets labor, but again, mentoring and industrial placements. So this is more of now applying the knowledge from universities into the sectors that students and learners do want to work. But there's an issue of partnerships as well. From an academic perspective, if you're pushing products and services into the markets, you need to have good partnerships with people who can market who can actually do more in terms of producing and marketing the products and services. And there's also an issue of, I've touched on production and marketing firms, investors. So once incubators have released spin-offs, this is a potential area to attract more funding. We have VC fundings nowadays and all sorts of that. But also it's more of jobs creation. When you bring new firms into the markets and products, they'll definitely need workforce. So by the way, you also have a chance to create more jobs in the informal sector as well as the formal sector. And another way is more of technology transfer. So from ideation, concepts, prototyping, to eventually having the capability to really release new technology trends into the markets. We see how much most of the current innovations in technology did start from universities, students who were doing research and academicians as well. And as I said, in the end, it's more of knowledge exchange. How is the mobility between the industry and universities? So do the students get exposed to both practical and academic ways of knowledge generation and application? Do the industry benefit more from people from the academia as well in terms of thinking and consulting and more of seeing how they can leverage that to advance economic and societal growth? And how about the opportunities for impact? So one of the areas that universities can do within their fundamental research is influencing better policies. And this can be in terms of improving education to be more contemporary, address entrepreneurship, design thinking, and all of those. But again, more into research and innovation within the knowledge spaces. And also, how can they influence, let's say, within government funding? How much % of it is really spent on research and innovation? Is there a room for them to improve that? And how are the structures in terms of infrastructure and the capacity of the state in coordinating and convening resources for that? And at the moment, with the issue more on inclusion, how is inequality addressed? Or how is inclusion really the forefront of all the research and policies that goes into facilitating innovation. And the last bit is more on the focus on bridging the gap on the digital divide. With subsidies and penetration of infrastructure, we're seeing the growth of access to internet, even in rural areas. Now, how do we take that into account in our policies to ensure that eventually when we introduce more contemporary technologies, all the intended users do benefit and don't feel left out within the society? And another core tenet is more on the education side. The capabilities to embrace and benefit more from the current global economy and value chains, even locally and regionally. This is more of improving curricula so that in the end we have graduates and innovators who know how to flourish in the market, as well as basic legal proficiency. So one of the key capabilities that are important and attract more skills and resources, more of institutions and places that have good mechanisms and policies to protect property rights, whether it's patents, intellectual properties as well. So it's important for innovators to know, to have basic legal proficiency and know how best they can do that in the market. But well, contemporary forms of knowledge, we have circular economy at the moment, which is more looking into reusing, the economy of sharing, rather than the linear economy that we've had for years. But also an issue of twin transition, as we are all concerned with issues like environmental concerns and climate change. How is that going in parallel with the digital transformation? How can technologies improve our pace to restore and mitigate climate change impacts? There's an issue on digital literacy. How well do we ensure that the education that's provided by universities across all spheres and disciplines, all the graduates go into the market with basic digital literacy, because it's one of the package of skills that everyone needs to have on their sleeves. And entrepreneurship education. This is important because eventually in a community, you want people from all disciplines who have the capacity to not only transform knowledge and use it, but also to see how that can be commercialized. And the last is more on design thinking. It's important that from ideation and conceptualization stages, that no matter what background the graduates and scholars have, they all have the capability to really articulate their thinking and see how best that can be propelled forwards. And this is the end. Asanteni sana.
Thank you, David, for quite a nice, captivating presentation on the role of universities in biomedical, in promoting innovations in this digital age. Do we have questions from the audience? Yes, we have one. Okay. Can we get the question from there, and we shall communicate the question to you very soon. And I have now. Oh, can we finish?
Anyway, mzee mwenyewe ndio nasema ni mama ni baba aliyefariki, mama baba. Wewe umesema binti Marwal. Umesema?
Sorry. Okay, please, can you, maybe we just can hear that question. Yes, okay. Mr. David? Hello?
Hello?
Yeah, you have one question from the audience here, and he's here to pose the question himself.
Thank you. My name is Prepini Kazoba, I'm a medical engineering student here at Muhas. My question goes as follows. From my experience in the rate of research I've done, especially on university students in the engineering aspect, finding their respective courses not fulfilling their expectations and they had to attend the universities, thus making them unhappy with their studies and hence reducing their school appetite, which makes them step back to creativity and innovation at large. What could be done by either the government or the university about that? Thank you.
Thank you for the question. It's a bit tricky, and I think I covered it in the bits of policy environment, because it's always important for people or actors to feel the support and value that academic institutions and public institutions can have and offer in terms of providing access and providing funding, as well as ensuring that their thoughts are well incorporated and accepted within paradigms. So it's important for universities to adapt that, and that's why in the capabilities I mentioned an aspect of good governance, because without that, then it means you won't have a room for participation, getting feedback from the academic or students community on what would be better in informing their learning experience. So it's more of evolution of institutions to incorporate that more. And I might have touched base on the society in terms of democracy. So democracy is really more of participation, ensuring that the members or the society, whether it's the academic community or the society at large, have a voice in ensuring that the developments and policies are inclusive and do cater for multiple pathways, whether within the academic within the academic environment or even out of academic environment, so that in the end, all these innovations can be accepted equally, but also the value and enrichment of universities in ensuring that there is sustainable pathway to growth, because most of innovations that don't leverage knowledge, because knowledge is the capital in the current knowledge economy. So still in one way or another, there's better value in sticking close ties with academic institutions. I hope I've answered your question well.
Thank you, David, for the response. And if there will be any question coming later, we will forward them to you through the chat and respond. With that, let me take this opportunity to welcome Felix to guide you on a stretching exercise for 10 seconds. Please, welcome.
The
This is for those who are-
Madam Rebecca, can you guide us, please? She's our admin, so she knows all the logistics. Ndio hapa mbele utusaidie. Can we all stand up, please?
Raise your hands. Go to the right.
Right. Left. Down.
It's down now.
No.
Down.
Then to the back. Check.
Rebecca. And that brings us to another series of presentation where I can see application of artificial intelligence. And the next presentation I'm told is by Dr. Felix Cruz, who is going to present on application of artificial intelligence in public health in Tanzania, prospects, challenges, and opportunities. Dr. Felix holds a PhD in medical informatics from Heidelberg University, Germany. He did his master's and bachelor studies in computer science at the University of Dar es Salaam here in Tanzania. Currently, he is a postdoc research fellow at the Center for Global Health Technical University, Munich, Germany. And he has over 18-year experience in information and communication technology industry. He is a lecturer, researcher, and consultant at the Directorate of ICT at Muhas here in Dar es Salaam, and he teaches and supervises students on digital health and health information systems. He once served as the director of ICT at Muhas between 2015 and 2020, and he is a member of the Tanzania Digital Health Steering Committee. With that brief, let me welcome Dr. Felix to come and give us his presentation. And hopefully, since his presentation is going to be very interesting, and since he's the organizer, he will kick it up. Thank you.
Thank you, Mr. Chair, my mentor and supervisor. All the good things that I'm going to say are more facilitated by Professor Simba, but if I do a mistake, it's fine. So I'm going to briefly give an overview of the use of digital technologies, specifically artificial intelligence in the health sector. And I know there are going to be specific presentation after mine, which are going to give detailed examples, but I'm focusing on prospects, challenges, and opportunities that around the use of technologies. I won't dwell much on digital technologies, but this has been covered including our presentations and the role of investors, and the speech of the investor panel also covered the importance of digital technologies. So we're focusing on exploring the use of artificial intelligence-related innovations with machine learning, deep learning, and lines in the health sector. And according to the recent document from WHO, it emphasized on the use of artificial intelligence that promise transformation in health service provision, research in all aspects in the public sector. We did a review which we noted, or we found that there is a limited knowledge in use of artificial intelligence in Tanzania. So we wanted to dive into looking at what is happening, what are the challenges or opportunities that can foster promotion. This is also motivated by our digital health strategy. It is Tanzania digital health strategy, which was tech in development, which promotes establishment of digital health centers, focusing on how to promote emerging technologies. As for the previous presentation, David emphasized the role of investors and research institutions to promote research and innovation. So we did a scoping review to understand what is happening in the health sector, specifically on the use of artificial intelligence. So the review was guided to look at key areas that we we indicated in red challenges, opportunities, as well as current implementation. What we found from the review is there are 16 articles that we found in our set, was focusing articles that were published in English and in the selected database using keywords that we thought are very relevant. Out of the 16, 11 articles are from the peer-reviewed publications, specifically journals, and this means they are reviewed. Sorry, since my slides are not moving. Please signal if you can see the movement of the slides online. Can you see slides moving? Yes. Apologies for the interruption. So as I indicated during our review, we found 16 articles that were published. They are specifically on the use of artificial intelligence in the health sector. 11 articles were in the peer review, 5 publications for great research, and this includes implementation reports of these various artificial intelligence related initiatives. So this is the table showing the 16 articles. We group them in table 1 shows the peer-reviewed articles, and table 2 is on the seems there's technical. Okay, apologies once again for, so I will do without slideshow. I hope you can see the slides. So what we noticed is there are areas that AI has been piloted. In most of the cases, either pilot projects on research or innovation hubs that have been implemented by various initiatives. As you can see in the first table, examples of where AI was used in the detection of malaria parasites, for example, prediction of perinatal death using death registries, SMC. Paper number 2 shows various areas where AI was explored, including exploring stakeholders' perception or acceptance of AI, including readiness whether Tanzania is ready. There's also implementation of AI-based innovations in prediction of supply chain management, including looking at seed stock levels and implementing the use of AI for assessing acceptance of public-based information. So you see, out of 8, AI has different models that I know that the demographics is going to talk with details about was machine-based, machine learning-based innovation, 8 of them, and then there are also deep learning components, and some of the applications didn't integrate models, but some also explored various models, like testing which model works better in various aspects. You see prediction of diseases and also exploring how we can better manage health resources on one of the areas that was explored. As I indicated, there were aspects of prediction of cholera using weather data, perinatal death using birth registries. And this is, for example, at SMC, there was one project on vaccine management, and so especially stock level management. And then the issues that cover perception of various stakeholders of the use of AI. So the review concluded, despite the few publications, there is a rising interest in the adoption of AI-based innovation in Tanzania. The review identified the articles that will be in the span of 3 years. You see, within 3 years, we have 16 publications talking on the topic. Several challenges were identified hindering use of AI-based innovation, including poor data quality, limited access to data, which has been raised by some of the innovators or issues related to regulations, guidelines, guide adoption and use of AI-based innovation, and also to recommend creation of neighboring environments. This covers issues of capacity building, both for AI engineers or experts, health professionals being competent on participation during the development of algorithms, models, and also training of the AI algorithms and models. Policies needs to be supported in aspects of data collection, data management, sharing, and also issues related to data quality and use. Some of the opportunities that we noted is despite having silos of data in different institutions, even individuals doing research, every researcher in most cases is or research data on its own computer or hashes. So this is an opportunity to leverage on the existing data sets that can be centralized and made available all in developing AI-based solutions. So there is a need to ensure the siloed systems are integrated or at least use the enterprise architecture approach in implementing the solution, and that's why in the morning we had aspects of enterprise architecture and the strategic framework in implementing the solutions. There are a number of systems that are in place that needs to be leveraged, but we also need to use existing international standards and also principles. It's, for example, principles of digital development, which emphasize on user-centric solutions. It doesn't support that you sit on your own, create your own solution. We need to work as an ecosystem to develop solutions, to test solutions before they are deployed, to ensure they are properly deployed, and there is a monitoring and evaluation component. Use of open source, open standards, there are also open AI models and open technologies, as well as content. And there's also now moved towards the use of global digital goods. Systems like VHS tools have been adopted for 10 years in our country, and they are treated as global digital goods. So we should address this standard and creating our own system from the start. There should be a fit between people, processes, technology used, and also data that they collect and use to ensure the ecosystem is well connected. So this is a story showing the principles of digital development, which looks at issues of sustainability, ensuring that the solutions that are developing are sustainable, be as scalable. We understand the ecosystem design for scale, that's issues. There are also issues we need to make sure issues of privacy, confidentiality, and security of data, as indicated by experts in auditing who indicated the need to ensure that the systems are well protected. We have digital machines or devices that are coming out with software systems. We don't know what kind of data they are collecting. We need to make sure they are properly audited and ensure privacy and security in the process. But it also emphasizes on collaboration between digital health experts, health professionals, be it students, be it faculty, researchers, and the government institutions, as well as the industry. This will ensure that we have improved visibility of quality data to inform decision making, and the essence is to ensure we have data and information. So, promoting the use of existing standards that are particularly digital development tools. There are other standards that we can explore online. Again, in terms of opportunities, Tanzania with a number of systems. VHS who are indicated as of 10 years, the team that are collected from thousands of facilities that we have in Tanzania. Over 7,000 facilities, for instance, even I did a review and the use of VHS to fix a lot of data. We are not using this data, for example, to do prediction of disease outbreak. How can you use AI to do data quality assessment? This has been a struggle. There's data quality analytics and but we can use tools like machine learning to assess data quality and inform promptly ensuring that data are collected properly and they are stored properly. Issues of disease surveillance, early system prediction. We have EADSR, which is collecting data of brain and integrated with VHS. A number of facilities have electronic medical records, but we are not exploring this. So this we treat as kind of city mines that are not being explored. There are lab manipulated information system. There are also disease-specific information system. Medicines, for example, HIV has been implementing a system, CTC2 database for almost 20 years. This information is sitting there without the use of AI. So the solutions, the possible use cases that we can see in terms of clinical decision support, diagnostics, prediction, but also how do we look at the individualized patient care using medical record and promote healthy lifestyle against these issues that the keynote speaker has talked about addressing SCBs, for example, as well in this system. So to support implementation of artificial intelligence in the health sector, WHO released recently a document on guidance on ethics and governance, which also focuses on some of the big cases that are existing in the health sector in terms of data quality, but there are also those things on AI, so it looks at the governance and how to ensure the solutions are properly designed and implemented. And there is also change and adoption component implementing the solutions and ensuring the systems are interconnected. There are also principles on responsible AI. AI has to be implemented in a responsible manner to make sure the tools are responsive to the needs of the community and different aspects that they say in terms of transparency and accountability, how can we ensure AI is fair. The solution that has been implemented in China really fits our context in Tanzania and lives. So in summary, you see AI, application of AI offers a lot in terms of transforming our health system, addressing, making sure the health system is responsive to the emerging and emerging challenges. We can use it for the promoting health, preventive and other aspects. It can minimize disruption in the health sector, but as we see, data is the lifeline of AI application. And we have a lot of systems that cause the number of data that we can use by ensuring that they are of good quality and also in an appropriate format that fits the use. And as you can see, we are also talking of data ensuring they are of good quality, they are available by standards, ensure privacy and security, interoperability, but important is also data governance that is also stipulated in the WHO guidelines. Ensure all the people involved in the ecosystems are catered for, clients, community members, community health workers, representatives from the presentation for Zanzibar, health workers, supervisors, health managers, as well as government institutions, ensuring people have required skills, incentives, and there are also institutional capacities to make sure AI is appropriately used. Our business processes are harmonized, and that's why we are promoting on the enterprise architecture approach. Policy standards and guidelines to promote use of AI ideas, but only enabling environment in terms of infrastructure, technological infrastructure, computing facilities, internet connection, and all other tools that are required to implement the solutions. We need to ensure the solutions that are implementing are client-centric. They promote client-based health-centered quality of care. So we are all called to ensure we appropriately design, develop, implement, and also make sure the technologies that we are implementing, be it AI or any other solutions, are responsive to the health system and will transform service delivery, research, and training. Mr. Chairman, participants, thank you for your attention.
Thank you, Dr. Felix, for quite a nice presentation that actually has revealed some opportunities that we have in some contexts that we are yet to utilize. Let me take the next two presentations in series because they both okay, I'm told Dr. Matt is there online. So we will have presentation from Dr. Matt Richardson from Sweden on digital microlearning as a tool for training and competency development
for personnel in elderly care to increase safety, effectiveness, and quality in professional practice. Dr. Matt is brief sketch of him. He's a doctor of applied physiology and a senior researcher at Malmö University in Sweden. He conducts research on policy, evidence, reimbursement, value, and effectiveness for health and welfare technologies. He has previously been Director of Knowledge Development at the Swedish National Public Health Institute, as well as the CEO of Sweden's Anti-Doping Agency. My trust is he's going to use the 10 to 15 minutes adequately so that we can also have time for questions if there will be few for him. Dr. Max, you're welcome.
Thank you very much. And I appreciate it, Muhas and our hosts for inviting me here. It's also nice to be speaking after Felix. We have a great deal of contact with him as well. So thank you for that. Can you hear me okay?
Yes.
Everyone can hear me? Okay, good. I really appreciate the fact that everybody's been presenting some very high-level topics. I'm going to do the opposite. I'm going to present a rather low-level topic, and I will share my my pictures with you so that you can actually see these. Does everybody see that presentation now?
Yes, we can see our presentation.
Good, thank you. Digital microlearning. This is a potential tool for helping training and competency development of people who are working in elderly care. And I say potential because that's what we're investigating at the moment. We're actually trying to figure out if it's going to work or not. And the reason why we're trying to figure it out is because there are actually a great deal of challenges in Swedish elderly care. We have a lot of staff turnover. People come and go very quickly in the branch. And a lot of the staff actually come with very limited education and skills. And in some cases, they're coming from other countries, so they don't actually speak the language quite well. And that's normally not a problem in Sweden, but when you're working with the elderly, a lot of the elderly are not particularly competent in speaking English or other languages, so Swedish is kind of important for them. And there's quite a heavy workload for these people as well. And of course, there was a small issue of a pandemic that happened in the last 2 years, which actually, unfortunately, managed to kill a lot of elderly people in Sweden because the infection rate got into the elderly care homes at quite a high level. So all of these challenges have been sort of directing us towards technologies that might be able to assist the workers that are working with the elderly. And one of the topics that we've been investigating is digital microlearning. Now this, for those who are not familiar with it, it's a very informal, personalized learning method. And what it does is it consists of very short educational modules. And we're talking about minutes, not hours, not even half an hour, usually in the neighborhood of 5 to 15 minutes to go through an educational model. And these are delivered on demand by the person that needs them, and often through their mobile telephone or some other mobile device, because you want it to happen where they're working and where they need the education right at that moment. So this type of learning has been used successfully in other populations, such as teachers, even with doctors and a few other kinds of areas, but it hasn't been tested among elderly care workers. So that's what our project has been involving at the moment. And we have 3 main questions we wanted to answer. We wanted to know, what needs do the elderly care organizations, and we're talking about the people that work there and their managers, what do they have for needs in terms of developing their education? What subjects do they need to know about? How much time do they have to do it? What channels do they want that to happen through? We also wanted to know specifically if digital learning could actually fill those needs. more efficiently than what they do now. And what they do now is they gather them and they have lectures, they may have some sort of online learning materials that span over half a day, but nothing that is quite short and tailored to the person themselves. And then we also wanted to increase the level of knowledge about dementia, about hygiene, and produce a higher quality care for the elderly, where they don't get infected as much and where people who have dementia are treated more appropriately. So we've been using 3 elderly care organizations in different municipalities in Sweden. This is a small pilot project, so we only have 30 participants, but we've taken 7 from each organization that work directly with the patients. And then we have 3 that are working with the leadership or the administration within those organizations, so that we get both perspectives. And the company that has developed the microlearning platform is called Minity. They are a Swedish company, but they're working internationally now. And their module is delivered by a mobile phone application. And I apologize that this is in Swedish, but this is some of the modules that you can choose from. There's modules on dementia, modules on how you keep your hygiene appropriate under the COVID-19 pandemic, and other types of strategies for working with people with dementia, for example. And essentially, the modules last for about 6 to 10 minutes. There's a series of very simple pictures and instructions that you learn about. For instance, this is from the hygiene module, how to actually wash your hands appropriately before you're in contact with patients. And this is all based on public sources, but it's immediately available through the application itself. And then at the end of the application, after 6 or 10 minutes, there is a series of questions that you're supposed to answer, only 2 or 3 questions, to actually tell you whether or not you've learned what you were supposed to have learned. So it's sort of like a self-test. Now, we've been doing this with 2 modules. We've been doing a hygiene module and a dementia module. And what we've been doing is we've been getting the users to evaluate the actual modules themselves and the application that delivers it. But we're also getting them to compare this method compared with the current educational methods they use. And in a lot of cases, those are very traditional methods, as I mentioned, where they sit in a classroom for half a day and learn about things. So that we're trying to get the actual qualitative and quantitative measurements involved in this project. And then we do a deep interview with all the participants as well to see if there are other types of modules that they would like to have developed. It could be about anything. Some of the ones that came up were about how to serve meals to people with dementia, because there are a lot of aspects that confuse the elderly who are dementia when they look at a meal. Sometimes if the colors are different, then they don't understand what they're supposed to be doing with it. If the napkin is black, then they actually think it's a hole instead of actually using it as a napkin. So there are different aspects that need to be taught here that a lot of people don't know about, and microlearning may be appropriate for that. Now, the results so far, we are in the middle of the final interviews, so I cannot give you the final results of whether or not this has worked because we are still collecting them. However, I can give you some early results. We do know that the application itself and the modules that we've presented to them have received very favorable evaluations, which means that they seem to think that the platform itself works quite well. It's very easy for them to pick it up, work through the modules when they're at home or at work or whenever they need to. So people thought it was very user-friendly. The modules themselves, they thought, were also quite good. However, they wanted them to be even more specific to their particular organization. And that means that they need to be more tailored. But of course, that's something that can be done by the company with time. The other thing is that a lot of the people have mentioned that they like to have a discussion about the things they learned, so that it may not just be enough to have a micro-learning application, learn what you need to learn at that moment, and then assume that you're done. There probably needs to be some kind of discussion that occurs in another forum somewhere else to sort of get other people's opinions on the material. But I think that's quite normal. Whenever you learn about something, you want to discuss it with other people as well. So I'm sure that may also be covered by the company, whether there can be some kind of chat function in there, or maybe even perhaps a dialogue forum that can be added. But that is what I wanted to present about digital microlearning today. As I said, we're just finishing the project right now, and when the results come out, then we will be publishing a lot of the information about on our website and in some academic journals as well. So thank you very much to our hosts here at Muhas and all of you for listening. And if you have any questions at all, my email is there, and you can just get in contact with me if you don't have any questions immediately. So thank you very much. I'll see if I can stop sharing my screen now.
Thank you, Dr. Mark, for the quick presentation. Let me see if you have questions or comments from the audience. Do I have any? There isn't. There are questions from the visual side? No. Then let me thank you again, Dr. Mark, for your presentation and for participation.
Thank you. We'll stop sharing now.
Yes. Now this brings us to the next presentation, which is going to be by Shabani Busega, Muhas, and this is about application of artificial intelligence in cancer diagnosis in Tanzania. And Shabani Busega is a third-year environmental health student at Muhas. He and other 3 students from Muhas have been learning various computer languages as well as artificial intelligence courses through online platforms from Harvard and MIT. Earlier in this year, in collaboration with 3 other students from outside Muhas, took software engineering courses and data science, and succeeded in developing an artificial intelligence model that can detect precancerous and cancerous lesions from microscopic images. And here he is. He wants to tell us his story. You're welcome.
Good evening. My name is Shabani Busega. I'm a student from Muhas. And I'm going to explain about our project based on application of artificial intelligence technology in cancer diagnosis in Tanzania. So I'm going to take you through 5 parts, starting with introduction, objective, methodology, and desired implementation. By starting with the background of the problem, currently many countries were facing a developmental change in cancer statistics, whereby most of the developing countries are the ones that are being affected. For example, in Tanzania, according to Global Cancer Statistics of 2020, there are over 40,000 new cases of cancer reported, with more than 26,000 deaths from cancer, whereby more than 60% of all deaths are women, with cervical cancer being the leading cause of death that account for about 24% of all deaths out of 35 different types of cancer, which is a bigger number. But despite of different efforts that have been made by the government, including establishment of the National Cancer Control Strategy, but still a problem that has been persisting for several decades. And one of the big problems is the diagnosis of cancer. More than 75% of all cases have been diagnosed at late stage, which makes it very difficult for them to survive due to nature of cancer. And this is contributed by several factors, including lack of screening services. In most patients There is still a story that before being properly diagnosed with cancer, they use it to move from one center to another, describing symptoms, describing disease, taking different medication without any outcome. It may take several months until when they get properly diagnosed with cancer, when it's already reached late stages, which make it very difficult for them to be medical, and only palliative care can be provided. Also due to the fact that the process of diagnosis is knowledge intensive and time consuming. In most cases, it's very difficult for a single pathologist to confirm a diagnosis. It requires them to be 2 or 3 or more than that in order to confirm. But still, we have few number of these specialists in our country. So our broad objective was to assess the accuracy and the effectiveness of using artificial intelligence technology in psychological and histopathological image analysis in the diagnosis of cancer in Tanzania. So to see how we can mimic the effect of insufficient number of health personnel and the limited resources in our base level hospital in diagnosis of cancer. So I will take you through the AI model architecture, data collection, and the model training, also evaluation and methodology. So our model uses a deep learning convolution neural network, or CNN, and this is a deep learning approach that can learn complex features and patterns from unstructured data like images. And traditionally, when we want to make a classification, it requires to specify a specific feature from an image in order to use it for a classification algorithm to classify those images. But with CNN, there is no need to find that feature. This neural network can automatically and effectively find a basic feature from an image. So it's a deep learning approach that can learn directly from a sample in a way that is more effective than traditional neural network. And through multiple layers, a CNN can learn different levels of features that have been set at different levels of abstraction so as to provide an effective classification. And by combining different architecture, for example, class activation map, it makes the model not only to be a predictive tool, but also can describe why and where to concentrate on a particular image so as to provide an accurate result in the classification. So in data collection, due to the fact that there is no available data set in our country that is digital images of different pathology of cancer. So we tried to look at a public online data set, and we found a CAG data set that combined cancerous and non-cancerous images of about 220,000 training images and 458 testing images. So what we've done is that we provide those training images, that is a set of images that have labeled or correct answer whether it is non-cancerous or cancerous, and then the model is learned directly from those images to find best feature for classification. And the next phase is to provide another set of images that are not labeled or are known images, and we command the system to classify it by its own. So that's right. So the evaluation of the model performance was evaluated based on accuracy that integrated both the true negative, true positive, false negative, and false positive, as illustrated in the formula. And then we optimize the model, and we optimize it by using Adam Optimizer, which is one of the best optimizer that can provide perfect adaptive learning in most of deep learning training of deep learning models. So after that, I will show you the video that show how to use this system. Then we will try to approve So this is how the model works. So the result was provided was accuracy of about 89%, with the detection time of about 2 minutes, not more than 2 minutes. And with cesarean, this is just due to limited resources, because in other large models that combine different AI and temperature, they've been able to go far up to 90-something percentage. For example, Professor Johan Launding, who is a medical professor from Karolinska Institute of Technology in Sweden, developed the same kind of technology that can detect abnormal cells from cytological images. And in 2018, was used in collaboration with Lokwete Hospital in Kenya, whereby it used to screen more than 3,000 women, and a certain number of cases were detected. Also, there is a company called the Landing Company in China, also used the same kind of technology in detection of abnormal cells in cytological images. And in 2018, also was used by Hubei province in its program of cervical cancer screening among women who reside in rural China, where there is limited resources. And within 8 months, it screened about 703,000 women, and about 35,000 pap smear positive results were provided. So this kind of technology shows great impact, especially in the diagnosis and the screening of cancer. So what we recommend first is availability of data. We're supposed to have a data set in order for training these AI-assisted diagnostic tools. And Tanzania has a large population, so it can provide a rich data for training and testing AI-assisted diagnostic tools. And this can be achieved, for example, through increasing participation, for example, in large-scale cervical cancer screening. When we perform analysis for millions of samples from different areas of the country, this will add millions of images to the data set that is used by that model. And through increasing data, that AI algorithm will be continuously upgraded, become more improved, and provide accurate results in a diagnosis or whether in a screening service. So another thing that we recommend is clinical setting holdout testing, to support clinical setting holdout testing. Because this model, for example, the situation that we are now, we need to validate. And in order to validate, we have first to convert those slides into digital images, and then we train the model by using those local data. And later on, the next phase will be to test it by comparing the result. We provide a known image to the model, and then the result that will be provided by this model will be compared to the result that will be provided by a certain number of pathologists. So if the model will provide exactly the same result as provided by that group of pathologists, means that this tool can be used as a good assisting tool in either screening or diagnosis of cancer in the country. Also, we recommend availability of lab, digital health lab, and this will facilitate further research that will be conducted in application, for example, of artificial intelligence in healthcare setting. And another thing that to ensure that there is inclusion, for example, of students, undergraduate students, because there is a tendency that you found that there are some students who are not, for example, taking BME, but they have passion to these things and they can do this, but there is a limitation that you are not taking biomedical engineering. So why you concentrate on this? But you can see that this kind of student has more even passion to do this thing and they can do this thing. But due to that limitation, you can find that most of people, they end up their dream dumping away. So this is what we recommend. So our plan is to start with cervical cancer screening using pap smear slides. So we plan to train it by using pap smear slides, and then can be used for cervical cancer screening in the rural areas where there is limited resources. Because in most rural areas or peripheral areas, there is high number of these cytological labs, whereby in most cases you can even access these services for cervical cancer screening. But the challenge is that there is no a skilled personnel in order to interpret these things. So another step will be cervical cancer diagnosis. by using biopsy for cervical cancer, and then digestive cancer, and later on to other types of cancer. As I said that we are working as a team. We are a mixture of medical students, data scientists, and software engineers with different working skills. And up to this point, I can say that thank you very much for listening.
Thank you, Shabani Sega, for a very nice presentation. I think we can start seeing the potential that we have in the youth among our universities. This brings me to the last presentation that's going to be by Dr. Deogratis Mbrikwa, who is going to present on how can artificial intelligence impact on healthcare system in resource-limited countries like Tanzania, and what are the future directions. Briefly, Dr. Deo has received his PhD from the University of Kent on the application of artificial intelligence. He previously did his master's on artificial intelligence at Tianjin University in China. And he has been researching and practicing machine learning, deep learning, image and voice signal processing, which are the core elements of artificial intelligence. And this he has been doing since 2012. During his time in China, he also works for GTA, a big data analytic company based in Shenzhen, China. And the company recruited him while he was still doing his master's degree. While in China, Deogratis and his friends formed a team that became second runners in the International Innovation Competition for Automation and UAV in 2014. And in 2019, he was among the 15 artificial intelligence researchers who received the IEEE Outstanding Young Investigators Research Visit Award to Sapienza University in Italy. His research interests are in the application of deep learning, machine learning, data analysis, and expandable artificial intelligence systems. With that brief introduction, let me welcome Dr. Deo to give his presentation. Thank you for yeah.
Yeah, participants, apologies, we are fixing a bit of technical problem. Those who are online, please stay connected. We are about to finish. This is the last presentation. We will be having 5 minutes slot. Thank you for your patience. I would also want to inform you that we recently received a small grant from Google to support AI initiatives. So Dr. is the lead on that, and the Muhas directed the project. So we really acknowledge the small grant that we received.
Thank you, Chair Professor Silva. Good afternoon. So basically, I will present on how artificial intelligence can impact healthcare systems, especially in resource limited countries like Tanzania. But I'll start by giving a short brief on artificial intelligence, where it is coming from, why now it is attracting a lot of interest, and it's already impacting our daily lives. So basically, artificial intelligence is not new. It started since the 1950s. But why is a lot of interest are happening now? You can see like since 1950s when artificial intelligence was mentioned in the conference at Dartmouth in the US. Then in the 80s when machine learning was being researched a lot, until then we have something called the winter period in artificial intelligence where there was no funding or no enough research in the area. Until 2010, when the technology like deep learning started to impact the practices of artificial intelligence. So why now everything is changing regarding artificial intelligence? This is mostly because of the advancement in computing technologies. From the previous speakers, you can see how many data they are talking about, the trend algorithm, things like that. We have Mr. Dan here who have been researching on biomedical devices. So because of this, the rise of this new technology, now we have access to tons of data, but we are largely limited on the computing technology. Looking back at the computing technology, this was in 1956 when for the first time artificial intelligence started being mentioned in the conference at Dartmouth. You can look at the supercomputer which was used to train the algorithm. It's large, so you can try to think in resource limited countries like us, what would you do? But 50 years later, Apple released its first iPhone, which could do more than 200,000 operations in a second. It could just fit in the palm of your hand. And now we have the GPU. This is a graphic processing unit, which you can just buy online. You just plug it in your computer and you can do amazing stuff at your home. So if you look where we're coming from and where we are now, it's because of this advancement in computing technology. That's why we can process tons of data. And thanks to biomedical engineers in the healthcare sector who are building amazing biomedical devices, we are now able to extract electronic medical records, electronic medical data to train our algorithm. And thanks to the technologies in the computing world, we can now train algorithms. Now we don't even have to buy all these devices by yourself. We can do it even over the cloud. So what's the state of artificial intelligence in Africa? It is still slow, but very promising. There's a lot of interest rising around artificial intelligence. According to a survey conducted by UNESCO, in around 32 countries which responded to the survey, more than 21 countries were putting artificial intelligence as their priority in their research, in their development plans. And looking at the global government AI readiness index, around 4 countries were found within the top 100 being in high risk regarding artificial intelligence in this country market. So it's nice to see Africa we're not yet lagging, but there's a lot to be done, which I'll speak at the end of my presentation. And yes, we've been talking about artificial intelligence, and very few universities in Africa are offering this course. Most of the practitioners of artificial intelligence have been self-teaching, doing self-teaching of this technology. But most of the available online materials just show how AI is amazing. Very few mention on the failures of artificial intelligence. Yes, it can fail. The same as human being. I'll show you a few examples which have shown artificial intelligence when it fails. This is Microsoft Tay. It was a chatbot released in around 2016. It had a Twitter account. You can chat with it, it can post stuff. Then on Microsoft realized Tay was getting offensive. She started posting offensive text on Twitter until Microsoft decided to remove it. So you can see if this happened to Microsoft, what about us? And Microsoft, they have money, they have the technology, so it can happen anywhere. Artificial intelligence can fail, and when it fails, it's really bad. And this is an Amazon recruiting tool, where it was just going through the profiles of the job applicants, so human didn't have to do that. But later on, they came to realize it was biased towards men and blacks. So it was rejecting a lot of applications from women and black communities. So Amazon stopped using it. I'll tell you the reason why I think that this can happen at the end. And this is another example where someone created an algorithm to track football during a soccer game. But later on, they came to realize instead of focusing on football, it was focusing on the referee's ball head instead of the football. So that's another example where AI can miserably fail. And this is Uber self-driving car with a fatal accident. And this one, we have facial recognition authentication, but it was cheated by using a 3D printer, not a human. So if you have a 3D print and I remember during my PhD, one of the colleagues from China who was researching about spoofing on facial recognition systems. Like you can just put a piece of paper on the face of the right person, and that will really to accept it. But all these kind of things are happening in research labs. When you go in public, you see how good is AI, but no one is talking about the sites where AI can fail. And the list goes on and on and on. And I remember another example of a huge company which manufactures self-driving cars. Their self-driving cars were rejected to be tested in London just because their algorithm put identify the land and iconic taxes. So when this exactly happen, why can AI fail? This can have, I will classify these mistakes in two categories. This can happen during learning phase. One of the points which was mentioned by Engineer Dan, that most of the time, especially resource-limited countries, we don't calibrate our biomedical devices. You can find a device which has been in use for years, or sometimes it doesn't even work. Then that device generates data. We use that data to train our algorithm. And if the device was not yet calibrated correctly, it means even the data is in question. If the data is in question, we can see what algorithm will be trained out of that data. So instead of just focusing on the data, we need to look at those devices which are generating those data to make sure we don't make this kind of mistakes when we're training our algorithms. And also mistakes can happen during performance. A couple of times you're waiting for an important email, doesn't come until you realize, let me check on my spam folder. So even Yahoo, Gmail, they can still make mistakes on classifying which this thing and where it should go. A couple of times we found important emails in our spam folder, which was not a response. So it happens. Now we're going to try to imagine what if this kind of mistake happened in the hospital. At least when we are in normal life, when we are not in healthcare, we can bear with those kind of mistakes. But in healthcare, a simple mistake can cost someone's life. So it's an area which we need to be very careful. So most of these mistakes that happen in our data, the trustworthiness of the data we use to train our algorithm, and also the efficiency of our algorithms. For example, one of the factors which we try to avoid in using artificial intelligence when we're training this AI algorithms accuracy, we try to use F1 score, which takes into consideration the two negative and the two positive of the algorithm to see how many times you can make a mistake. Because if someone comes with cancer, then your algorithm says he doesn't have cancer. Then that individual will go home happy. Then after some time, when you realize the cancer, maybe it's already stage 3 or 4. But if you do that early, by taking into consideration these factors, we can at least minimize this kind of mistakes. So I'm coming with this recent trend in artificial intelligence, responsible AI, to try to avoid this kind of mistakes. So responsible AI is the governance framework that recommends how specific organizations are addressing the challenges around artificial intelligence from both an ethical and legal point of view, through development and the deployment. So we try to address this from the development to the deployment of the algorithm, make sure we don't cause harm to our end users. There are basically 4 principles in the responsible AI, and this has been pioneered by the WHO and even the IDRC, a lot of funders who are trying to support artificial intelligence. We are moving into responsible AI to make sure we don't cause harm to the end users. So there's underscore fairness to make sure your algorithm is fair. I spoke about putting agent at Amazon, which was biased towards blacks and women. So we try to create algorithms which are fair. And also transparency and explainability. Can you explain the result of your algorithm the same way a radiologist is doing? I will show you an example now on how to do that. Towards the explainability and the transparency. And also to respect the privacy and security. The data you're using, was it collected ethically? And the algorithm which someone is using, is it secure, is it safe? And also human centeredness. We have to make sure that every algorithm you're creating is towards saving humanity. So those are the core points of responsible AI. And if we try to implement all of this, I think we'll be in safe direction. So I'll go a bit more on explainable AI because I'm more interested on researching on this area and I've done another work. So explainable AI is an artificial intelligence in which the result of the solution can be understood by humans. Previously, we used to call AI algorithm black boxes because I have the neural networks inside and they can't explain how to do the AI decision. But if we manage to create results which can be explained to human, it will actually save us even through regulatory traffic. In contrast to the concept of the black box in machine learning, where even its designer cannot explain why an AI had a specific decision. I will show you one of the examples. Let's say you want to create an algorithm which can identify trends. So you have pictures of trends, right? Then you have your neural network. Perfect, it can identify a trend. But going back through explainable AI, look at the image. The direct part of the image. That's where the algorithm was looking. It was not looking at the train, instead on the railway tracks. So this was identified through explainable AI. So try to imagine you have this kind of algorithm, you deploy it in the self-driving car. You want to cross a railway, but it identifies the railway track as a train, so you have to stop. You stop there forever, waiting for the railway tracks to go, so thinking it's a train. So this is where the importance of explainable AI comes. I'll show you another example. This algorithm was created by Tang to try to diagnose TB on chest X-ray. And the areas marked with the red cycle, those are the areas which radiologists identified that, okay, this is TB and because of this. But when you try this algorithm, it pointed exactly where the radiologist would say. So we can trust AI, but we need to explain our AI. We need to explain the results. And these points should go into regulations to make sure all the algorithms going out can be trusted, and also shouldn't be the last fair decision. My personal experience on explainable AI started 2-3 years ago. It was with a brain-computer interface. Brain-computer interface is when a human interacts with the environment by using the signal from their brain. This is an example of EEG device which used to extract the electroencephalography signals from the human brain. So if we want this kind of technology, the BCI, to be implemented in our real life, we need this kind of devices, EEG, to be used. But we are not expecting to see people moving in our street. We are in this kind of device, and the trying to control maybe is a lamp, like a cycle. And this one just has 64 channels. We have devices which are with 248 channels, so this is small. Another one is this one, which have 32 channels. But we don't need this. So it started in I think it was 2017, in the first project, where we were trying to use EEG signal. The project are using 64 channels to help people who have lost their limbs of this kind of amputated, really amputees from China. There are 4 of them. I think 2 of them lost their limbs through accident. One was, I think, war. Then after training the algorithm, which was able to decode their multi-imaginary intention, like whenever you're moving your body parts, the decision starts from the brain. And the brain will send the signal through your nervous system to the arm which you want, to the muscles which will control the last part which you want to move. Like try to imagine for someone who has lost his limb. So the signal will be generated from the brain. They go out through the nervous system, but there's nothing to control it. So for now, instead of just having artificial limbs which you can control, there's a trend in PCR trying to have artificial limb which can still control by just thinking or what you want to do. So we trained this algorithm and it was able to detect around 5 of the imaginary intentions. Then we went back to explain our AI. The intention was to see which part of the brain will be active when this individual is trying to perform the activity. Luckily, it showed in the most part which were very active because in the motor cortex region of the brain, which tends to be active when someone is intending to do something. But look at the third participant. In those red areas on the topoma are the ones which generate the signal when someone is intending to do an activity. But if you look at the third participant, the red is only on one side. So it was through explainable AI when we came to realize that something was not right. Went back to the people who collected data in China, and they said this individual was complaining about pain every time when he was about to perform a certain activity. Went back to the neuroscientists who told us about something called phantom pain. Phantom pain is the pain someone feels when they want to control a certain part of their body, and that part is not there. So actually, through explainable AI, we are able even to detect someone who was going for pain without that person mentioning. So after this research, we came to realize that it's possible to have just tiny EEG device to revolutionize how BCI is working. We work on another project by using EEG for studying with potential. This is when you trigger the EEG activities of the brain through flickering light. And basically, after doing the explainable AI, we came to realize that the only part which was active during this SSVP was just at the back of the brain, which is the visual cortex region of the brain. Then we came to realize that it's possible to have just a time sensor, which can be stuck on the particular part instead of having these huge EEG devices. Then our friends in the US who were collaborating, they managed to manufacture a tiny EEG sensor, which is flexible, it's wearable. You can put it on the screen for 2 weeks, and you live your normal life. And it's already patented in the US. So the future direction, where should we go? First is the policy development. As I've shown you how AI can go right, and it can go wrong. So we need policy to guide how AI innovation should happen. Instead of just blocking it or just leaving it free for everyone to do it, we need to have a policy towards the development of AI solutions. And also we need regulations. Not every product should, not just everyone should just sit in their bedroom when the AI algorithm released to the market. So we need regulations to make sure that we are taking out products which are not going to cause harm to the society. And also in data sharing, here we build the lucky that we have medical, we are a medical institute, and we have hospitals just outside which produce tons of data. And there are a number of projects which are going here which produce tons of data. We can take advantage of that. So data sharing is an important aspect to make sure we have enough data. Like from the previous presenter, they had to use data from cargo, while they're just next door to the hospital. So we just need those kind of data for young generation like this to have build their solutions which can help us. And the last one is validated medical data center. We need to have a medical data center, but the data set should be validated. We start from the devices which produce this data to make sure we are collecting the right data, which is not biased to avoid all this kind of problem. Thank you. I will take questions.
Thank you, Dr. Dale. Quite nice presentation. And now the 3 presentations on AI are open for questions or comments. Yes. If you may.
From the beginning of your lecture, at the beginning of your lecture, you just mentioned the importance of the medical device regulation, how the medical device could affect the results of the AI solutions. So the question is, do you think it's not the right time to grow the AI application in our medical facilities, or we need to wait until the situation of medical devices in our facilities? And also, since you know that maybe you might have an issue with what's good to have
Thank you, Gina. I'll start with the second question. As a unit, we have a plan to do a simple study on the medical devices, the status of medical devices, how well they are performing, all the procedures. First, are they being used right? And also, if they're being calibrated, are they being repaired, maintained in the good status? Because that will govern the quality of data coming out. And speaking of, if we still ready for to deploy AI solutions, I don't have a clear answer to that. I'm still resistant to that. I don't think we are yet ready. but we have to take it slow to make sure the rules and the regulations are in place and we have clear policies. Because if we rush, we are going to cause harm. Because there's a lot of questions arising. Because with AI, if an algorithm makes a mistake, at least with a human, when you know if a human makes a mistake, we know who will be solved. But if an algorithm makes a mistake, who are we going to solve? So I'm a bit slow on accepting if we are ready for that. Because even in the US, I think the last time I checked, there are very few FDA-approved solutions of AI in the US. And taking the superpower, all the technology, all the money, but they're still very slow on that. So for us here, I think we need to take it slow, but we don't have to close on the innovations happening. We have to take advantage of it. Thank you.
Thank you. Let's hear from Professor Aiko. Engineer Dan, sorry.
Okay, sorry.
I very much enjoyed your presentation. In 1999, I did my master's thesis on artificial neural networks with imaging. And I mentioned I'm an imaging expert. So one of the issues with this and also the previous presentation is the issue of multi-scale. So for instance, when you're comparing photographs of cancer cells, they have to be the same magnification. If you're presenting different magnifications as a training set, you will totally, and I'm wondering, how have you handled that, or how have you, because 20 years ago, multi-scale was the way we talked about it, but that really didn't produce results for me, so just wondering.
There's a technique in artificial intelligence, I don't remember the exact name, but what we do with that, you can never single image. Most of the time we use it when you have little data sets. What you do in that technique, you can do different operations on the same image. Like you can do zooming in, zooming out, rotate the image, flip, move it out, move it in a bit. So there are those kind of techniques which you can do on the same data set. Because when you are collecting it, maybe the zooming was just at 20 times. You can go back to it. So using that technique, I'll try to remember the name. You can do this kind of operation. So your algorithm will get to see all different zooming. Even you can throw some maybe noise on the data set, which the algorithm can still pick, like when someone fits in an image which is not of the best quality. Okay.
That's where the difference in processing power makes a huge difference.
Exactly.
Thank you for that. Maybe please welcome and you come closer so that you come next.
Thank you, Dr. Mzuriko. I have a question to Mr. Busega. So I have two questions addressed to you. The first question is, on the CNN model that you have addressed, can it be implemented to diagnose other disease? And the other question is, has the model been used in other countries? And if it has been used in other countries, how efficient has it proved to be?
Thank you for your question. The first you asked about the CNN model can be used for diagnosis of other types of diseases. But CNN is a deep learning model that the ability to learn or have the ability to make better performance in extracting features in unstructured data like images. So equal disease can be diagnosed by using analysis of an image. CNN can perform that. That's why I said that it can be used for cervical cancer screening, because in cervical cancer screening, you can use pap smear cells. Also can be used for diagnosis of any type of cancer that include the analysis of images. Also, another question is that efficiency, that you said that, that this kind of technology have been used in other countries. For example, China, Sweden, and many other countries. For example, there are some companies like We hear funds like about systems, also Philips use the same kind of technology. But this kind of technology is quite different from others, because when we want to use in our country, it is better to train it by using data from that country in order to show better performance in classification of medical diagnosis. That's why it's recommended that if you want to use it, it's better to train it by using local data. That's why we emphasize to have a support in order to train it to be used in our country.
Thank you.
My question is very simple, but out of curiosity as well. And my friend. Yeah, I just want to get your insight on this. Is there a fidelity of this information? What do you look at it?
I see it in both sides. It's the same as when the hacking technology came. We have white collar hackers, people who hack to steal money. So it's the same will happen in artificial intelligence. And actually, this in European countries, I'm not sure if this is already happening in data protection. People are trying to protect users' data, but here try to see we're using WhatsApp for free. But the company who own WhatsApp, they're billionaires. So why are they billionaires? Look at what's happening on online. You can go on Google, search maybe for a car, just random, just search for a car. Tomorrow you will receive an email from Before asking you to buy a certain car, which looks so similar to what you just said the other day. The kind of adverts which comes in your feed. It's the same as what you are doing online. The same if you go on YouTube, watch a certain kind of music or whatever. The next day you open YouTube, you start seeing a recommendation of the kind of music exactly of what you are watching the other day. So in fidelity, I don't think we are safe as long as we are using internet and data. And with that, we don't have that power. And if you look at the rest of artificial intelligence, the leading one are the ones which have access to massive data. The US, that's where Google is coming from, YouTube, Facebook. China, they don't want to use Google. They have something they call Baidu. Google is not operating in China. WhatsApp is not operating in China until we have this VPN. They have their WeChat. They have their own social media, which they know what's happening. Even the recent race regarding the 5G, the banning of the Huawei and everything. If you have 5G, it means you have access to tons of data with high speed. Once we have people's data, you can just do anything. I remember a simple study which we did by using data from Twitter during COVID-19. What we saw online was similar to what was happening on the real world. So it's just a good. So as long as you're connected to internet, you're not safe. Thank you.
Thank you.
Question online. There's one online from Tom Newman.
So the question goes, which funders are interested in funding digital health solutions in Africa and or in Tanzania? And what are their expectations? Are they willing to wait for you to get things right, or do they want to see returns of their investment within a particular time? Felix, Leo, who want to respond to that?
Thank you, Tom, for the nice but a bit tricky question. Because I don't have to take all the most of the projects that you see happening in Tanzania and Africa are either donor funded or co-funded by the government, and they are particular in the areas of interest, for example, in the health system building blocks. The supply chain, they are partners who are interested in the supply chain, so they want to transform supply chain management. It's health service delivery, it's health. So we are US-based funding agencies like NIH, UK, Trust, what foundation is supporting AI-based solution, or application. So we have a lot of Swedish citizens supporting our ICT program to use of ICT in learning, research, and teaching. So there is also an answer of who, but a lot and the teachers have been increasing. In terms of expectations, we want to be responsible because they are research-based or project-based. They are tied to project objectives. So they are supporting objectives with projects. And because they are not, say, business investments, in terms of the kind of investment in one of the project, are not mostly not project-based, say, profit-based investments. I think that's one.
Okay. Okay.
So with regards to the use of AI, we have seen the call for different development support. I'm not speaking on behalf of the ministry, but I just want to put that the group will be participating in developing AI vision for the health sector, that is there in the Ministry of Health, the SEMI and other partners, including PATH. So the ministry is looking forward to create a vision, which is also going to dive into the development of various segments. I know there are initiatives that's coming up in terms of developing, establishing adaptation acts, and then regulation that's also going to support them in terms of access to that, and access to each other. They are also, if you look at when we are doing review, we looked at when there are existing policy frameworks in other countries. Other countries like the US, Russia, even develop their vision and policy of the use of AI in the health sector and other sectors. Either they are still in the development phase or they just developed. Some are 2019, 2020, latest 2021. So when you see the developed countries, they don't have the clear document stages on how AI can be used in the health sector and other sectors. So we are not late. It's a call for an ecosystem that is going to support the government to provide evidence from our research so that the regulations are going to be established to support AI. Thank you.
Thank you, and I think we need to clap for the three presenters. A big applause. And that brings us towards the end of our symposium. And unfortunately, the director is not there to close the symposium, and on his behalf, I will give some few remarks before I welcome the organizing chair to bear farewell to all members who attended. Let me first thank all the participants, those who managed to come here, and those who participated through the virtual media, for participating throughout the whole day. The day has been long, but I could see that you all have stayed from the start to the end. That to me shows that the symposium was worthwhile and was interesting. And let me also take an advantage, since given the mic, to try and say a few words to the Muhas Digital Health Initiative Research Group, that on the whole day, you have received a number of recommendations or comments that I believe they are going to be quite useful to you and your partners that you are working with in terms of taking digital health forward. If I can mention a few, there are issues like doing research, trying to find those things that have been found to work in other countries, especially in developed countries, just like the one you have mentioned recently. But how can they work in our settings? What can work, what cannot work, so that we don't take issues the way they are from other countries and apply them in our country blindly. You also have been, we have been told about documentation, that documentation is very important, and I think this is a challenge to the research group in terms of documenting lessons that our country is undergoing or has undergone in terms of digital health, doing research, doing evaluations, so that you can be able to document all these things that we have been talking about here, so that they can be there for people to easily access and see them. There's the question of auditing. To me, that was an eye catcher because I didn't know that there was auditing in IT solutions. I thought auditing is in money and managing human resource. So we are developing IT solutions, even at Muhas. We have IT solutions being developed at PRL, at Ministry of Health. Unfortunately, we didn't get opportunity to get responses on to what extent such auditors have been involved in developing these systems. So I think you as a research group will pick that as an issue and carry it forward. There is the issue of artificial intelligence being able to predict epidemics. And we in our country are experiencing a number of epidemics, not only COVID, but we still have cholera, yet we cannot predict it. So here, to me, is a challenge. How can we use digital health to predict epidemics? And we have young university students here who actually, he introduced himself coming from environmental health, and epidemics is one of their big challenge, I'm sure, in their courses. So sure, I think if you use him, you can get a leeway to try and see how we can use artificial intelligence to predict epidemics in our country. Biomedical engineering, you have been given a challenge. The sentence was, it belongs to medical school. The master level, the PhD level, the high quality level of learning can only be produced at Muhas. And as far as I'm concerned, I can see this research group taking that challenge forward and providing the evidence so that whoever that matters can participate in addressing that, that challenge. And last but not least, we have to take the caution that IT solution is not the end in itself. It has to be there to solve problems that are facing people. So we should be people-centered. And with that, or those few remarks, let me again thank you for listening, for comments, for questions. And before I say that this workshop has been closed, let me invite my co-chairperson to say a word and finalize the workshop. Thank you very much.
Professor Simba Daudi, thank you very much for chairing the session. I'm not sure if I deserve to be a co-chair because you did it yourself. Can we have a round of applause? So, who are last in my word of thanks, but I will start thanking you for your time. For your commitment to support us and guiding us through, and for your very elaborate conclusional remarks and directives to the group and Muhas community in terms of taking forward the digital health and innovation agenda. So I'd like also to thank the following who have managed to make this event a success. We call it a success because I'm going to sleep very well today after a night of preparation and nights. So I thank all of you, but as the speaker, I want to thank Swedish International Agency for supporting ICT and library program, which has had this event as one of the initiatives. So thank you for their attention and thank you for the support. And we remain hopeful that we will continue supporting some program and such initiatives in the future. We thank the University Management for placing these events right from the planning phase towards the opening where the guest of honor active vice president addressed the events. But we were also glad to have the approval of Vice Chancellor Professor Pende, who was very committed in supporting us in providing comments to our program, and we are looking forward to this event. But unfortunately, because of the loss of daughter, Benedetta, we dedicate this event to Benedetta. Yesterday evening, I visited his home. He asked, how are we going to manage the event? He said, we have to visit the and we are there to also so the university is very supportive and we are appreciative of this. I would like to appreciate the invitation from the presenters, including the keynote speaker, all the presenters. Can we have a round of applause? So I call this a professional social responsibility. We are used to corporate social responsibility, but they have done wonderful professional social responsibility. They are here up to infinity. We will just offer them a certificate of appreciation for what they have done. And we are looking forward to further events. We expect this to be an annual event, so we are going to ask them again this year during this session. We are even appreciative to the government institutions who have participated in this event. The Ministry of Health, President Office of Administration of Government, e-government agency, and join virtually. Unfortunately, we couldn't make the presentation. Post-day, we are also doing online. I thank you, partners, SPAS, MPH, etc. with us. This is we thank Nani. He has been very resourceful. We didn't have a planning session last week. With a short notice in minutes. We thank all the participants. We registered 160 participants online. The records that I have stated. So some of them joined Zoom without any registration. ensure that we are more on this. We say asante sana for your active participation and comments, questions which are going to be into our stress as well as last but not least, I'd like to thank the members of the organizing committee. Can you please stand up so that we can basically the wonderful work that you've done. Here we are. Okay. You are part of the I thank Tanzania Broadcasting Corporation, our national brand area, BBC. Thank you for your welcome. The one towards this. We again invite you for further events that are going to take place at Muhas. This is just the beginning. I will see more from Muhas distributor space, but in all of other areas. The final call is we have shared the link for you to provide your feedback, questions. We are going to compile all the questions and answers from the participants or around physically and virtually, and post them on our website for your reference. And if you have any additional questions, we will also have a link on the website that you can ask questions. I see a lot coming from students. They really need to understand the information system, and there are some other issues that the ministries and other partners need to act on. So we use this platform to engage. Finally, I call this an end for this day, but at the beginning of the planning phase for the next year. You are mostly welcome as the designer.
We're gonna